It is 9:03. Rather, it is April 17th, 2025 at 9:03. The board meeting of the Oregon State Board of Nursing is now called to order. A notice of this board meeting was published by Rachel Prusak, Executive Director, in accordance with the open meeting law. If necessary, the board may also meet in executive session as authorized by ORS 192.6601, ORS 192.6602F and L, ORS 678.126, ORS 676.165, and ORS 676.1751. The board members and staff stating that they are present are attesting to understanding the confidentiality of executive session and have taken steps to ensure that the executive session proceedings are not observed or heard by anyone not authorized by public meeting laws, ORS 192.660. Is there a roll call by our secretary?
Yes. Marcus Cooksey.
Present.
Margaret Hill.
Present.
Claire McKinley Yoder. Present. Joni Kalis.
Here.
Linda Stanich.
Present.
Oleniki Tobola.
Present.
Rachel Dennis.
Here.
Felipa Nesta.
Present.
Rachel Mitzel.
There being a quorum present, I declare this board eligible to conduct its business. Is there a roll call by our executive director?
There is. Good morning, members of the board. I am going to start in the lovely back corner, the corner that I sometimes forget and have vowed not to. So if you could please announce your name as we move around the room.
Gretchen Cook, RN LPN practice analyst and board staff.
Laura Blackhurst, nursing education policy analyst and board staff.
Kimberly Goddard, Chief of Staff at OSBN. Lauren Rauch, Assistant Attorney General assigned to the board.
And we have, go ahead.
Randy Ritter, Executive Assistant.
And for those of you attending virtually, staff, if you want to announce your presence.
This is Sarah Wickenhagen, APRN Policy Board Staff.
And this is Amanda Musin, Operations and Policy Analyst, Board Staff.
Great. Good morning, everyone. And Rachel Prusak, Executive Director. And then before we jump in, do you want to allow the three new board members to introduce themselves since they haven't gotten to our public and policy?
That would be great. Why don't we start on this side with board member Nesta? Would you tell us your a little bit of your background, why you're here, maybe?
Okay.
No, or whatever you feel like this morning.
Had to make sure the mic was on. My name is Felipa Nesta, I'm LPN, and my background is I worked for Kaiser since 1997 and kind of just bounced around. Most recently, I was in the ICU for 17 years of that, which I worked the COVID unit, and I loved it. That's fun to say, but I did. And I learned a lot. And that's part of why I'm here. I'm part of the SEIU Local 49, and my president came to me and told me about this opportunity. And I was like, yeah, that sounds great. And definitely different than what I thought, but it's been great. And it's learning stuff. I was like, oh my gosh, but it's great. And I feel like everyone's a great group to be with, and I'm looking forward to see where this takes me.
Mike, sorry.
My name is Rachel Mitzel, and I'm a Central Oregonian. I've been in healthcare for over 20 years. I started my healthcare career at OHSU as an anesthesia technician, and then became an RN, worked in the ICU, went to school and became a CRNA. I'm currently on the board of the Oregon Association of Nurse Anesthetists, and am excited to join the board, Oregon State Board of Nursing. I am also a psychiatric nurse practitioner, and I am trying to take that brave step into private practice, which is entrepreneurship is not for the weak-hearted at all. But I'm excited to be here today.
Hi, I am Rachel Dennis. I am a CNA at Sacred Heart. I've been there for almost 12 years now. Let's see, my whole family was in healthcare, which kind of got me into it. And then I'm also on the executive board for my union, SEIU Local 49. And our president was like, "Hey, I think you'd be good at this. I think, might be interesting." So I was like, "Okay, yeah, I'll give it a try." And yeah.
I think everyone shares a similar story that we don't often jump to leadership unless somebody pushes us. So thank you all.
Okay, and as we're looking at our agenda for the day, I wonder, are there, I don't think there was any change to the agenda that I got from last week. Are there any other modifications, anything reordering, or anything we need to do for the day? And then, okay. And then, so the first item we have is the approval of the consent agenda. The items listed there. And in our packet from page 8 to 21, was there anything that any of the board members wanted to remove from the consent agenda to discuss or had questions about? You guys a moment to. No? No? Okay. Then are we ready to make a motion to approve the consent agenda?
I make a motion to approve the
Oh.
consent agenda.
Usually the staff,
Am I off? Am I usually the one that does it and not the board?
yeah, usually one of the staff members,
Oh,
not necessarily
I'm happy.
your, but,
We were all in this room together yesterday, so we know where my brain is a little bit. So, I make a motion to accept the consent agenda, and apologies.
So moved. Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey,
aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Tolabola,
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Okay, and the next item we have are our board meeting minutes to be approved for the in-person meetings of February, for which I think 6 staff, or not, our new board members were not present for. And then, so we'll start with that, and then we've got the March virtual meeting. Were there any changes to the meeting minutes for the February in-person meeting?
I did, I did notice that on the Thursday, February 20th, page 31, it says, Board President Green called the meeting to order. Do not believe that is correct.
We will correct that.
Right. So with that change. Anything else? Okay, I think we're ready for the motion to approve that. The board meeting minutes for February.
Good. Board members, I make a motion to approve the board meeting minutes as modified.
So moved.
Seconded.
It's been moved and seconded. We'll do a vote. Marcus Cooksey,
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich.
Aye.
Oleniki Tolabola.
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
I mean, I think that since we're approving with our current board, I would imagine we approve with the current board's vote, but I would wonder what Council Rouch, is there any need to clarify that, or?
I don't think so. I think we're
Okay.
good. Yeah.
Thanks for pointing that out. And then as far as our meeting minutes for the virtual meeting in March, were there any corrections that anyone noted? Sounds like not. All right, so I think we're ready for the motion for that.
Members of the board, I make a motion that you approve the meeting minutes of our virtual meeting in March.
So moved. Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitchell.
Aye.
The motion has passed.
So we can now turn to Policy Analyst Ju to discuss administrative rulemaking proposals.
I'm going to jump in for just 1 minute and remind everyone when they vote or speak to turn on their mic. I know it's a hard reminder. Thankfully, I have 2 people on either side of me that does it for me if I forget. So maybe we'll all help each other out if we find that our person sitting to the left or right of us also forgets. So thank you.
Mr. President, members of the board, my first agenda item is on page 43, starts on page 43 of your packet. And it's on proposed adoption or revision of Oregon Administrative Rule, Chapter 851, Division 61, for permanent rulemaking. So the board approved the draft changes to Division 61 at the February 20th board meeting. A public hearing was held on March 18th, 2025. At the hearing, no comments during the hearing about the division, but we did have a CNA member who joined, who shared her personal experience as a CNA. And this was included in your public rule hearing packet that you all received from our rule coordinator, Brandy. So these rules are presented to the board this morning for consideration for permanent adoption to go into effect on July 1, 2025. And this is to align with the consolidation of the CNAs. Questions?
Great, thank you. I think we're ready for a motion on this.
I make a motion that the board approve the final adoption of OAR Chapter 851, Division 61 as presented.
So moved.
Second. It's been moved and seconded. Let's do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitchell.
Aye.
The motion has passed.
Thank you. So the next item, Mr. President and members of the board, is on page 80 of your packet. And board approved the draft changes to Division 62 at the last board meeting. And then following that, a public hearing was held, same meeting on March 18th, 2025. No comments during the hearing about the division, but again, the same CNA shared her personal experience as a CNA, and including your packet for the rule hearing. And presenting these rules this morning for consideration for permanent adoption to go into effect on July 1, 2025.
Great, I think we're ready for
Okay.
motion.
Thank you. So I make a motion that the board approve the final adoption of OAR Chapter 851, Division 62 as presented.
So moved.
Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitchell.
Aye.
The motion has passed.
Thank you.
Thank you for all your hard work in getting this through. All right, we can now turn to Policy Analyst Blackhurst for some administrative rulemaking discussions and proposals.
These are,
All right. Good morning, Mr. President, members of the board. I am going to be directing you to page 107 of your packet, where you'll find a memo regarding proposed revisions to the Oregon Administrative Rules in Divisions 21 and 51. And for clarity, this memo, discussion, PowerPoint presentation are all going to be related to agenda item AR3 and AR4. So I am going to walk the board through sort of the process we went through in updating Division 21, and then go rule by rule and try to quickly summarize the key points of what is changing. So a little bit of background. First, Division 21 has been undergoing revisions since 2023. However, renewed work really began in earnest in spring of 2024. The goals in updating these divisions have been to really align Oregon with national and regional regulatory trends, to remove unnecessary barriers for nursing education programs when we find them, to simplify the regulatory standards by developing one set of administrative rules for academic institutions, and to really increase the accessibility of the Nurse Practice Act overall by, again, clarifying, simplifying language. I really want to highlight for those final 2 points that Division 21 has rules for LPN and RN programs. Division 51 has rules for APRN programs. And one of the immediate challenges we identified is that often one institution might have 2 different levels of program. And so they're held to 2 different sets of administrative rules. To really illustrate for the board how maybe Division 21 and 51 have drifted over the years, here is a snapshot of all of the different rules that are currently in Division 21. So you can see there's a lot of different aspects of a nursing education program we regulate at the LPN RN level. But when you look at Division 51, very different amount. And so one of the big things we've tried to do, again, is really merge these divisions together, bring 51 into 21, and then moving forward, we are not going to experience this drift between the different levels of programs because they're all working out of the same set of rules. And then to give the board a little bit of context about the timeline of this work. So from April of 2024 through July 2024, that is when we really did our research into, again, these national, regional regulations. We worked by looking at the National Council's model rules for education programs and developed an initial first draft of Division 21. In mid to late summer, July through October, we took that first draft of Division 21 to our advisory committee. We held 3 meetings and received a significant amount of feedback from the advisory committee at each of these meetings. And I also want to note that our advisory committee is a little bit larger than many of the others. It has about 25 members. And not only does it include nursing administrators, nursing faculty, but we do have representatives from community colleges, private institutions. Director Prusak, on her tour of the state last summer, was able to connect with rural education programs and make sure that representatives from these small rural schools had input. And Director Prusak also did a really helpful job of finding these nurses who work in different healthcare systems that are responsible for working with schools to get clinical placements and making sure that their voice was on the committee as well. And so, like I said, we received a lot of really good feedback from our advisory committee. From October of last year till January of this year, that is about how long it took us to go through all of that feedback, really think about it, investigate it, again, look at it in context of regional and national trends, and develop a second draft. That was completed in late January. So February through March of this year, once we had our second draft of Division 21 completed, we went right back to the advisory committee. And thankfully, we only needed one meeting to hear all of the feedback. And so I think that's a good sign that we heard changes, we implemented changes in the draft, and there was a lot less things that they were identifying as maybe this should be tweaked. So our third draft has been completed, and this is what I'm presenting to you today for consideration, is our third draft of Division 21. So from here, I'll move to going rule by rule. So the first rule is proposed for amendment, and this rule is the purposes of standards. Again, this rule is just having its language clarified and simplified, and it is setting the standards for the rest of Division 21. And so with all of the work to revise Division 21, what we're doing is aligning the outline that's provided in this rule with all of the changes that will follow in Division 21. The next rule is Rule 10 about establishment and approval of a new nursing education program. This is being proposed for amendment. We are simplifying the approval process from 5 steps to 3 steps and remove redundant requirements. So in my table below, you can see the old process involved a letter of intent where nursing programs needed to publicly declare that they were starting a new program. That sort of occurred outside of the nursing program even engaging with the board. And then there are 4 additional steps after that point. So what we did is remove the letter of intent step because we could not find evidence of other boards doing this. We combined the preliminary and developmental steps for the nursing program, and then we retained the still having a step before you can admit students, and then a full approval step. Rule 12 is about accreditation requirements of nursing education programs. This is a new rule we are proposing for adoption. So this rule will require nursing programs to obtain national nursing accreditation. For our current Oregon programs, we have outlined that this must be achieved by July 1st of 2029, so that would be 4 years from the effective date of these rules. And then for any future programs that arise, the expectation would be the same. It's still going to be 4 years from the full approval of their program. Additionally, this rule establishes documentation and reporting standards surrounding accreditation. So anytime a nursing program is communicating with their accreditor, the expectation is that they are copying the board on that communication. The image here is a current snapshot of the states requiring accreditation of their nursing programs. I've shared with the board previously, this is a growing national trend. And so we see our neighboring states, Washington, Idaho, Nevada, even Alaska and Hawaii themselves are requiring national nursing accreditation already. The next rule, this is 15, continuing board approval of nursing education programs. And so this rule underwent a lot of revision to simply reorganize it by starting with the routine procedures first. The rule, as it was phrased previously, sort of outlined all the different exceptions and then had routine at the bottom. And so for, again, simplicity and clarity, just reorganization. We also simplified the survey process and aligned it with the requirements of accreditation. As much as possible, we would like to survey nursing programs in alignment with the surveys they're going to receive from their accrediting agencies. We've also clarified in this rule why the board can authorize a survey and included a timeline and expectations. This rule has also incorporated information on the deficiency process. So if we do continuing approval survey and we identify deficiencies, what are those next steps? That currently lives in a different rule. However, as much as possible, trying to put related information together in one rule, I think makes it easier for nursing programs who are reading these rules to follow the process. This is our rule on NCLEX standards. So this rule is being repealed. However, I want to clarify these standards are not going away. They are being reorganized. So we are moving them into Rule 70, which is about outcomes and evaluation. My argument being that one of the key ways we evaluate the outcomes of a nursing program and evaluate its quality is looking at its NCLEX pass rates. And so it made more sense to me not to have a separate rule, but to move it into outcomes and evaluation. Rule 20, denial or withdrawal of approval. This is being proposed for repeal. However, this is the rule that I was just sharing is being reorganized to move these standards into Rule 15 about that continuing board approval. So these concepts are not going away. They're simply being reorganized and, again, putting all the related content together in one rule. Rule 25 on reports and approvals. Again, this rule has been greatly reorganized just to start with our routine procedures. We've also clarified and simplified what information needs reported to the board. So we've removed barriers around requiring programs to have their administrator, so their dean or director, be approved by the board before they can take on that role. We've removed requirements around reporting on admissions and enrollment. We've also removed some barriers on a nursing program opening an extended campus because it's considered the same program. We've also added some processes surrounding education tracks. So some examples of that are many RN programs like to have an LPN option or exit. While that happens here in Oregon, it's not actually been codified in Division 21 in the past, and so we're putting that language in. Another example might be an advanced practice nurse practitioner program that maybe has an FNP track, and now they're looking to add a new adult gero track. And so how does that process happen, and how does the board get notified of that change? And then we've relocated content from Rule 45 around nursing faculty. Our rules have always provided a path for exceptions for faculty to the qualifications for faculty roles. Because it's a thing that needs approved, to me it made more sense to put it in the rule that outlines all of the different approvals. All right, Rule 30, consultative services. This is being repealed. We had a rule that had references to board staff offering consultation to nursing programs, which we don't typically provide. Rule 35 is about closing of an approved nursing education program. So this is proposed for amendment. Again, clarifying, simplifying that process for when a nursing program closes. We also were able to really align these rules with standards that are already prescribed by the Higher Ed Coordinating Commission, because they have rules as well for when an institution is closing. And so we didn't need to repeat their rules. We could refer to their rules. Rule 40, education program organization and administration. This is proposed for amendment. Again, we've updated, clarified the responsibilities of the nurse administrator. We had a redundant mention of the nurse administrator being board approved prior to taking on that like dean or director position. And we relocated some information in this rule from a different rule about record retention. All right, nursing faculty, Rule 45. So this is proposed for amendment. We have removed barriers to faculty roles and revised qualifications to align with regional and national trends. Oregon, we found, actually had more requirements to be a nursing faculty member than many of our local states, which was a huge barrier in nursing programs hiring faculty. We've incorporated standards for APRN program faculty into this rule as well. We've clarified some of the expectations around faculty professional development and updated our guidance on clinical ratios and supervision. We've had some confusing language about community-based placements in the past. And so we've really shifted from speaking about community-based placements to thinking about who is supervising the student in the placement. Maybe they are out in the community, but our rules, when we limit them to this community-based setting, it limits the ability to put students in settings like clinics or SNFs. With that, we frequently use the phrase meaningful presence in the rules, and no one really knew what that meant. So this has really been updated to talk about, in this placement, who is supervising the student. Is the expectation that the faculty is there supervising the student, or with your clinical partner, have you come to an arrangement where one of the staff will be supervising the student? I see you have a question.
I do.
Yeah.
I was just looking at this rule, and in number 1, C, says a program may have no more than 25% of its full-time faculty comprised of nurse educator associates, faculty appointed by exception. Does that mean that only 25% of the faculty can be nurse educators, or what is that? I'm not sure how to interpret that.
Thank you for pointing this out. I was under the impression we had actually removed this line.
That was the intent, was to ensure that happened before the final copy. So maybe
Yeah.
we can double check that, and then maybe at the vote it will have to be modified.
Yeah.
So let me look. But given the question, do you want to maybe share why we came to that decision?
Absolutely.
And then I don't think we've gotten to the part where you kind of define the differences, what you did really well with the deans and directors lately. So, but we can look for that.
So thank you for pointing that out.
It is, thankfully, it was just looked, and it is removed in the track changes. So,
Okay. But the clean copy has it.
okay.
Okay.
So then there, we just need to rectify that the clean copy looks at the track changes, and it is supposed to be removed.
Yeah. So allow me to give a little bit of context for that. So this was a line that was in some of our earlier drafts of Division 21. However, some of the major feedback we received from nursing programs is around the struggle to hire faculty who are either fully qualified and not on an exception, or that balance of nurse educators to nurse educator associates, which I can explain in a second. And given the feedback from the nursing programs we worked with, we identified that even though this is a recommendation that comes from National Council to have to make sure that your faculty are all fully qualified without exceptions, it was a barrier for Oregon programs, and identified that it might cause more harm than help. And so the intent actually is to cross out or delete 1C in this rule. And then let me clarify as well, the rules identify, actually in this rule, the role of the nurse educator and then the role of the nurse educator associate. So a nurse educator is typically a master's prepared nurse. There are some options outlined in the rule for those nurses who maybe have a non-nursing master's degree, but we think of them as master's prepared. A nurse educator associate is someone who has a bachelor's degree in nursing. A nurse educator associate, the expectation is that they work closely with a fully qualified nurse educator who is overseeing her work. because that master's degree and preparation is typically where these nurses are getting the experience and learning around teaching, around curriculum. The rules that currently exist in Division 21 additionally require several years of experience for those two roles. For the nurse educator, currently it's 3 years full-time patient care experience. For the nurse educator associate, it's 2 years. One of the other changes we've made to the faculty qualifications is not being so prescriptive as to the number of years and that it has to be patient care experience, because none of our other local states are regulating it that way. What they're more commonly doing is saying that your faculty has to have this education, but then they have to be academically and experientially qualified for a faculty role. And so by taking out a number of years, we make it easier for nursing programs to hire faculty. That was a very long-winded answer. Does that help?
Lauren, I have one question on, I'm sorry.
Yeah.
Policy Analyst Blackhurst. I have one question under 1A.
Yes.
So I am wondering, it says the final evaluation must be made by a faculty member.
Mm-hmm.
I feel like for a clinical experience grading, it actually needs to be a nurse educator. It needs to be a nurse who's making, because I'm just looking at the non-nurse faculty.
That's a great point. We could insert the word nurse by a nurse faculty member.
Okay, just because it seems important for clinical evaluation for it to be someone who is a nurse.
Yes.
Thank you.
Thank you.
I did have a question on in the qualifications.
Yes.
So you said that the removing the 2 years in patient care or 3, whatever, the patient care experience aligns with the states around us. Does that mean that someone who, so like, could I go get my RN, my BSN, do all of that stuff and become a nurse educator without really ever having touched a patient on my own?
I think we are trying to make sure that any nursing role could become a nurse educator. And one of our things we considered is that there are nursing roles that don't necessarily directly touch a patient. And so when we have the prescription of they must have patient care experience, that excludes any nurse who went into a nursing role and maybe worked in that role for years and decades, but it wasn't patient facing. The other thing that we spoke to our nursing programs about is that nursing programs often really value hiring these faculty who have a lot of experience. There's nothing that bars them from doing that here. So they can still choose to look for faculty and look for candidates that have, like more experience than others. That can be part of their hiring rubric. But for us to mandate it does limit nursing programs.
And,
Does that answer your question?
and Policy Analyst Blackhurst and Board Member Dennis, if it's okay, I'd like to add to that just a little bit. It's going to share a little story of a little bit about my ignorance and what I've learned in this process. As somebody who's been a clinician, boots on the ground for over 20 years, I always felt, how could somebody have the experience to lead a program about patient care if they haven't done it or haven't continued to do it? And then I had my own experience working at OHSU for 9 months before coming here. And I really learned that being a great clinician doesn't always mean that you're a great educator, and that it really is about understanding being a nurse educator. And if you are in that role, you should be able to teach anything. So it was a real, a big change of how I thought. And then, of course, being a part of Division 21, listening to educators, it really changed my kind of almost bias of me thinking that. And then the only other thing that I would emphasize is that what we were having discussions on is what is the role of the Board of Nursing to regulate, and what is it on the role of the deans of programs to decide who and how they hire. So I hope that helps too, because it was a real big change of my thinking during this process and understanding.
Yeah, that does help. Thank you.
Yeah, thank you. Okay, are there other questions on this rule, or I will keep going? And of course, we can always come back. You do have a question.
It's just, please continue.
Continuing my quick tour. So Rule 50 is on curriculum. So this is proposed for amendment. We are updating some terminology in this rule. Currently, Division 21 talks about nursing practice experience. We are changing that to clinical component. Not only do our statutes use the language of clinical component, but in talking to all of the stakeholders around the state, people know clinical, people don't know nursing practice experiences. We removed the formal requirement of a final practicum, but again, that is an option that is retained for nursing programs, and there are some rules about faculty oversight if they choose that option. We removed some redundant information and simulation rules. We set the limit to 50% from 49. 50% is the evidence, so I thought we should go with that. We've updated curriculum requirements to align with the nursing roles that are described in Divisions 45 and 55, and then incorporated here information from Division 51 on APRN curriculum standards. All right, Board Member Mitchell.
I'm sorry, I just have another question.
Yeah.
So I read earlier in this document, that when a new school or a school looking for recertification, they give you a proposed plan of, for clinical placement. And then here it says we're now focusing on clinicals. I know that one problem, for at least in the APRN role, is getting adequate clinical placement at schools. A lot of times the burden is left onto the student to find clinical placement, and they are paying individual practitioners out of pocket outside of their tuition, which I'm thinking doesn't provide them with a clear, like a unbiased assessment of their clinical judgment, because they're paying outside of the school for access to clinical hours. And how does this document going to prevent that or safeguard the emphasis on a good clinical experience or a student with good clinical judgment?
Yeah, two thoughts come to mind. So the first one is that this document doesn't expressly prohibit that. However, one of the things that we look at when we're evaluating a program is that they have adequate resources for students. And we absolutely consider clinical placements a resource. And so I think on evaluation of a program, that is something we would probably note, and myself or whoever is in my position in the future would bring that to the board, this finding of this program is not providing this resource to students. It's putting that expectation on students. And so I think this is how that document would address that.
So when a program applies or gives their application of their clinical, do you double check with the clinicians providing the clinical experience, or is it just the program saying, yes, our students all have opportunities for clinical experience?
We are not double checking clinical placement.
So there's no safety check, basically.
Well, as a new program, they have those multiple applications that come to the board, and to get that full approval as a program, we do go out and survey them. And so we might discover at that point what you're describing regarding clinical placements. I think otherwise for none of our nursing programs are we sort of monitoring at that level.
Okay.
Seeing some of these before, that the applications from the educational institutions, they include sort of letter of reference style from their clinical placements that really confirms that they have those. Not that it's required or that it's always there, but they often do. So.
Okay. I just don't think that we could meet those goals for, demonstrating clinical proficiency when you have an ethical dilemma. Because if a student is paying privately for clinical experience to an individual practitioner, not through their school, how can they be fairly and unbiasedly judged?
Yeah, so board member, so there might be more that others want to say, but the challenge around clinical placement is real, and it is brought up in every space that I am in, every meeting that we're on during Division 21, every meeting that we're on with deans and directors, every call that I have with a legislator. It really is, I'm sure maybe Oregon Center of Nursing, at their presentation today, it might get brought up. It is a real challenge, right? And not just in Oregon, across the nation. And I do think there's opportunities of how the board could potentially weigh in. And you bring up a really interesting point, and do think it will be discussions along the way in years to come. But at the end of the day, it really is, what is our role in it? And I think that is still to figure out. I don't know.
You
if
know,
there's-
related to that, I'd like to know, you know, when the surveys are done, sort of what percentage of clinical placements are compensated to the clinical placement? Like how much versus, like, I would assume sometimes the school will pay or compensate a clinical placement for it.
To my knowledge, on the surveys that I've conducted, I have not actually seen a school compensating for a clinical placement.
Which is one idea. I wonder, especially with the advanced practice clinicians, a lot of the preceptors are unwilling because they're not, the amount of time, like say if you have 20 patients a day and you're going to also precept, right? Versus if there could be a small compensation, the organization could say, oh, we'll give you 2 less patients a day. I don't know, it's just one of the things that I think, versus like, as Board Member Mitchell pointed out, falling to the student to compensate their, it just seems better if that's folded into the educational institution. But I'm just curious what more, if there, it sounds like, or even the question too, of what percentage of students might be paying for it, because I don't know how much anecdotally your stories, how they line for what percentage
I
of.
think it's fairly frequent, at least a lot of kind of online boards that student boards, since I was just a student recently, students are paying for that. But I know that in the state of Washington, they now have a legislative rule where they are compensating clinical preceptors to kind of combat this problem through the state.
That's been brought up about what other states might follow, and does the state have money? And I'd venture to say that I'll be interested to see how long that lasts in Washington, knowing their budget shortfalls. But
Yeah, and we also
Yeah.
have a lot of folks that are getting certainly for advanced practice RNs, their educational institutions outside of Oregon, which is outside of our jurisdiction, even
Right.
though their clinical placements may be here.
I think one possible workaround, and I don't want to get too off track, is that if schools make clinical instructors adjunct faculty and give them perks like,
But there's a number of different avenues.
yeah, that's one of the topics of discussion, is how we have these clinic program partnerships. It's something that's a big discussion and leaning into, because again, where do we have a role in it? And then where are we part of the discussion is really the big thing.
right, and I just think that since we're changing this language or to focus on the clinical experience, that we're stating that we have more of a role maybe than we used to.
A lot of our language around clinical is unchanged. I think one of the big changes we intentionally tried to make for our nursing programs is that reaffirmation that clinical can occur in any setting where a student impacts a health outcome. We've been having a lot of conversations about the importance of having students out in community settings, that nursing school should not just be acute care clinical. And so that is kind of the direction we tried to push this language slightly, is, again, clinical can occur where you impact a health outcome.
I just have a question about, and I know that they may still be allowed, their schools are completely allowed to do a precepted final practicum
Yeah.
experience, but it's no longer required. So, but because we have this new accreditation requirement,
Yeah.
that also kind of looks at some of the quality of school. Is that, but, so when a new school starts, it could be, I think, up to 7 years,
Yeah.
you know, because of going through all the approval and everything. So I feel like in Oregon, we have a good hold on that.
Mhm.
We have oversight. But when you have somebody who's coming in as an endorsement applicant,
Mhm.
how does the program that they graduated from still have that? Like if they were in the first 2 years of a 7-year cycle, like how does that accreditation, how does that,
Mm.
when we're looking at how their
Yeah.
education matches up with?
So our intent was to require that accreditation piece on the program, but not on the applicant itself. And so, like, if you are endorsing into Oregon and you did not graduate an accredited program, that's still okay. There's actually only one state that requires, that puts that requirement on the applicant. Where the applicant has to demonstrate they graduated an accredited program. And I think especially because, like you were saying, if you're a new program, for the first couple of years of your program, you can't actually get accreditation. And so we don't want to, like, bar these students who are going to a new program going through that process.
I guess my biggest concern is the quality of the education of the nurse who's coming to us, because we know that out there are programs that are, that end up having, you know, legal difficulties. And so, if we don't have that piece of, like, they have to graduate from an accredited program, we potentially have nurses coming in who are underprepared to be nurses.
Yeah.
So,
I see what you're saying. I think that would be more addressed in Division 31 because it's a standard for licensing of those nurses versus the standard on the education program itself.
Well, yeah, I think it would be too, but also just going to challenge us to say, well, does that mean the same for Oregon nurses now going to other states? Because we don't have that now, right? So, but
other states do, though.
no, we don't, our programs aren't accredited, so nurses leaving here that have been trained here, and if it was put on them, they would be considered not good enough now.
Well, some programs
Yeah,
here
yeah,
aren't, but
yeah.
a lot of them are.
Yes.
And I think that does limit them going to other states, is there.
Did you say only one state does
Only
it?
one state, to my knowledge, requires, that puts the requirement on the applicant to show that they graduated an accredited program.
Okay, I'm sorry, like, you're right, it's that accreditation piece where it's kind of taken out of the hands of the Board of Nursing. But I guess what I meant is, many other boards of nursing have very strict requirements, like down to the number of hours for having, maternity direct care experience, which, like, I don't think that's what we want to do.
True.
But where is that middle ground where they have sufficient, so we don't have those really strict rules anymore. We won't have those around our education. I'm just worried that I would like a little more guardrails, and maybe that's that it needs to go into Division 31. And so, but in the meantime, do we have a lot of people who are slipping through who are not from programs that we would deem appropriate? I guess that's my concern.
Yeah, and I think I will say this, and then we should probably continue to focus on 21 and what we're before us today. But I think, you know, without specifics, what I would say to that is we're not in the compact. We're one of the few states not in the compact, allowing us to do transcript review, and we have a thorough process to ensure our transcripts that are coming through meet our requirements that are in our statutes, our rules.
I have a
Okay.
quick question just related to this. Do you feel like then, given this discussion, that there is a trend nationally that states are requiring programs to become accredited?
Yes, I do believe that. We do see that every year or two, another state or jurisdiction is moving towards requiring accreditation. So that was one of the things we considered, and should we require it or not?
Right, so that could kind of help your concern, right, as more states adopt this, applicants are going to be graduating from accredited programs.
Is it 65% currently
It's like 63, I think, or 60.
of yeah. Mhm.
Yeah.
Policy Analyst Blackhurst, I have I think it's maybe oh shoot.
Oh no.
I think it's a Scribner issue.
Yeah.
In number 7A,
Okay.
APRN program curriculum must meet all educational institution requirements for and culminate in the award of a doctoral degree. Sorry, Mike.
That was page 1.
Yeah, I see what you mean.
And I was like I kept rereading it.
You know, that language is repeated in 5, 6, and 7A. What we're trying to explain is that
But so my question is the for and together.
yeah,
Or
a comma.
and culminate in,
'Cause-
comma.
Yeah.
Is that, all right, I can insert commas.
Cause I kept rereading it and rereading it and
Yeah, so I should make that change to be consistent in 5A, 6A, and 7A.
thank you.
Yeah, thank you.
Well,
I'm terrible at commas.
Down on me.
Thank you. I have a question about the final practicum.
Yes.
Just curious, what other states require a final practicum?
When I was doing my research, I couldn't find evidence of other states requiring a final practicum. You know, a lot of schools do, because I think it's such a great learning opportunity for students. But again, that role of what does the board regulate versus what does the school do?
Accreditation.
It looked like boards weren't really regulating it.
Okay.
Yeah.
Not really. And one other question, maybe you know, roughly,
Yeah.
of our current educational institutions, what percentage are accredited?
I believe approximately 61% off the top of my head.
Close to 2/3. Thanks.
Yeah, and I know that a number have, you know, really, because they've been so engaged in this rule process, they're already having the conversations about getting, moving towards becoming accredited. Okay. Continue my tour. Maybe. Uh-oh. There we go. Okay. So Rule 51, you may recognize this. This was the temporary rule we adopted a couple months back about exception requests for clinical experiences. This is that temporary rule that if we want to keep it, we need to permanently adopt it, because otherwise it will expire in July. And I think as we discussed back in January, this rule was meant to provide flexibility for nursing programs when something extraordinary happens and they suddenly lose clinical placements and need to pivot for a semester. It's a process that allows them to submit to the board plans for like replacing clinical experiences, primarily with simulation. Rule 55 is program responsibilities to students. So this is proposed for amendments. We are clarifying what information programs have to tell a student applicant, including travel, articulation agreements, program policies. We clarified the standards for students when they're in the program. Oregon Health Authority has requirements primarily around things like vaccination, OSHA training, things like that. And so we clarified that in the rule, and then also included these clarifications around the expectation that programs provide support services to their students. Even if students are, you know, off on an extended campus, they still have to have access to support services. We have a new requirement that programs must have a documented process for remediation of clinical incidents. And we removed language on board limits on eligibility to really align with some of the changes that happened in Division 31. Yeah.
under the things that students should be informed of, you know, it occurs to me students should know maybe NCLEX pass rates for schools.
It's a great point. We do publish that on our website, the pass rates, the first-time pass rates of our Oregon programs. Do you think that satisfies that, or would you want it?
I mean, if a student's going to put up money, time,
Yeah.
effort to go to a school,
Well, see, I just like Chris, do schools promote that on themselves?
They often do.
Yeah, I thought,
promote that.
I feel like they do, and Oregon Center Nursing Director saying, yeah, so.
Yeah.
I'm glad that we do on our website and that it is at the school level, but, I just, want clarity around what else would need to be added.
Yeah. I think one of the challenges that comes to my mind with the NCLEX pass rates is that when we get to that rule, there are going to be multiple different ways to calculate it. And so that's why I sort of like the idea that we, as the board, continue to publish that information with our data on the first-time pass rate. I think that way it's more consistent with what's being presented to students, if that makes sense.
do we only do first-time pass rates?
That's what we publish, yeah. Okay. Continue on. Rule 60 is a rule I have for repeal. However, this was about record retention, and so we just relocated this content into our rule that's otherwise about organization and administration of the program. Rule 65 was about facilities and resources. So again, here we're just updating and clarifying language. This rule previously contained information about clinical nurses and preceptors. My experience in this role is that no one is looking in facilities and resources for that information. And so for clarity, we put it with nursing faculty. Outcomes and evaluation. Oh, you're right. So this is proposed for amendment. We are, again, clarifying and simplifying the requirements around a program's systematic plan of evaluation. Again, because we're moving towards requiring accreditation, this is a huge component of accreditation, so we did not need to say as much in our rules. This is where we relocated the NCLEX standards. Again, it's an outcome and evaluation of the program. And we increased flexibility in the pass rate standards with multiple paths to meet the pass rate standards, really attempting to align with what accreditors are commonly looking for. And accreditors often offer multiple different ways to calculate a pass rate, whether we look at first time or total pass rate, or we look at 12 months or 36 months. And so programs can be flexible to meet the standard in the way that works best for them. Rule 80 is standards for reentry programs. This rule is proposed for repeal. This is about program and faculty requirements for reentry programs and processes to approve reentry programs. We've proposed this for repeal to kind of better align with our statutory authority. Oh, sorry.
Well, no, so I just have a question.
Let me go back.
Because we like that's one of the ways that people can reactivate
Yeah.
their license. So is it because it's not, because it's a way that they will be able to reactivate their license, is there some other way that it's being regulated?
So it's interesting because, again, looking across different states, there's no consistency here in how this gets regulated. And this is not a program that leads to initial licensure. It's something different. And so the expectation moving forward would be that students could still, or applicants could still attend a reentry program. It's just that we're not regulating it.
But it could be anything.
It could be anything.
Like, so it could be like I did, 15 hours of CEs by some random person and they signed me off as doing every, so that's what I'm just wondering, like, is there, because we're kind of depending on that reentry program in decisions around like reactivation. I mean, like, I
Yeah.
think it would be important for the board to understand, that, the quality, and so I'm just curious how.
I think one of the things we've discussed is that potentially this is another area in Division 31 where we could add standards for if you want to do a reentry program, your program must meet like XYZ criteria to be accepted. Any other questions on this one? All right, I think this is my last one. Maybe? No, you're good. All right, so 90 standards for out-of-state programs. So again, this has been simplified and clarified. This rule, the language in it was quite confusing, and so just clarifying what the expectations are if you're an out-of-state program. We have changed it from approval to notification surrounding clinical placements. And this rule also contained a lot of information about programs related, like located in Oregon, which was confusing and redundant because this rule is about out-of-state programs that are coming here for clinical. Part of the reason we are backing away on this and changing it from approval to notification is that, again, these programs aren't operating in Oregon. They are out-of-state programs that are making an arrangement with a healthcare facility in Oregon to offer a clinical placement.
I have another question.
Please.
So I'm just thinking for APRNs, because there's a limited scope of practice in many other states compared to Oregon's, for APRN programs. So will we also require accreditation? Then I would think that if they're accredited, they would be more likely to have a
Yeah.
full scope of practice as an NP.
That's a great
APRN.
question. So one of the challenges is we can't put requirements on those programs because we don't regulate them. They're out of state.
Right, but we've said that, we're saying that they have to be, approved by their nursing regulatory body. So we've already put some restriction.
That's true. So they do have to be approved by their regulatory body, but it would be on the regulatory body of that state to require the program to be accredited. Yeah.
Add to that, my understanding too, from when a APRN from a applicant from another state, or even just for renewal, there is a piece about prescribing. There is like there are educational pieces, requirements within there. Like from what I remember, there's like educational video, or there's some other stuff that speaks to the difference of the scope of practice of Oregon versus others. That's what I recall when I got mine.
I was wrong. I have one more slide. Thanks, Brandy. All right, and so Division 51, as I said, like the goal has been to pull those standards from Division 51 into Division 21, and I just wanted you to see a snapshot of how that's occurring. I know I talked through a lot of it, but on the left are the 4 rules in Division 51, and on the right are where we've pulled that information over to Division 21. So I think I discussed a lot of those as we went through, but just to be very clear about those changes. Okay. I do have 2 additional edits I need to make the board aware of. So the first one is that we identified the term judgment is actually spelled 2 different ways. I think there's a British and an American spelling. So we would like to spell judgment without the E in the middle. And so in Rule 0050, it occurs twice, and I'm just going to take the E out of judgment. And then our new rule for adoption around accreditation, that was Rule 12, we needed to include on the draft the statutes we were citing for our authority. And so to that rule, I'm going to list our statutes, ORS 678-150, 678-340, and 678-360. Those are the changes I have. Are there any other questions or things you'd like to discuss?
I just want to take one moment
Yeah.
and publicly state how extensive this process has been, with you coming back to the board and speaking to them, checking in with them, while leading very extensive, intense, spirited debates and discussions, and really looking to standards across the nation and where we're going, in education. So thank you, and to the board for all the work you've been doing in between it also. And then I did track the few changes, and I'm sure everybody beside me did too. I don't know if it's helpful to call them out when we do a motion, or make sure we all have the same ones. Just thoughts on that? So I'll just share what I have, if that's helpful. So I have 1A, adding nurse faculty, on page 15, 1C, delete, 115, sorry. 5A, 6A, 7A, for the love of the Oxford comma, judgment, ensuring that they're all spelled the same, and adding the statutes. Anybody have anything different?
Are you ready for a series of motions on this one?
We are, and thank you for that presentation and answering questions that were peripherally related
Oh,
to
I'm
your
happy
topic
to
today.
answer, clarify. All right, then I have several motions. So my first one is that the amendments to OAR 851-021, 0000, 0010, 0015, 0025, 0035, 0040, 0045, 0050, 0055, 0065, 0070, and 0090 be approved as modified.
So moved. Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
You want to pause for 1 second?
Yeah, I think we need to clarify that these are approved to go
Rule
to
hearing.
rule hearing. So I just
Not
want to make sure
approved.
that we need to be clear, the board's not actually voting to approve them, to adopt them as rules. So if we could let
Do you want me to
policy
read?
and yeah, can we please, thank you.
Sorry, lots of O's,
but,
yeah.
I'm sorry.
It's okay. All right, let's just do this. Okay, I motion that the amendments to OAR 851-021, 0000, 0010, 0015, 0025, 0035, 0040, 0045, 0050, 0055, 0065, 0070, and 0090 be approved as modified to move to rule hearing.
So moved. Second. It's been moved and seconded. Let's do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
For my second motion, I motion that the adoption of OAR 851-021, 0012, and 0051 be approved as modified to move to rule hearing.
So moved.
Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
For my third motion, I am motioning that the repeal of OAR 851-021, 0018, 0020, 0030, 0060, and 0080 be approved as presented to move to rule hearing.
So moved.
Second. Been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
My final motion, I motion that the repeal of OAR 851051, 0020, 0030, 0040, and 0050 be approved as presented to move to rule hearing.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Johnny Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Tolobola,
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
Thank you. That's all I have.
Do you want to take a break now before, instead
And then
of
we'll consolidate all of,
on? Yeah.
Analyst Cokes. That's a good idea. Okay. Then why don't we break, the original schedule said till 10, we do 10:35, 10:35, and then Polyanalyst Coke can review both the items she has on the agenda. Okay? 10:35. All right, I know I said 10:35, but we're all back and we're ready to go with the next item on the agenda. This is for Policy Analyst Cope.
Great. Thank you, and good morning, President Cooksey, board members. I respectfully direct you to page 167 of the PDF board packet, where the exhibits for rulemaking for OAR Chapter 851049, Rule number 10, Scope and Standards of Practice for RN Protocol Utilization, and Rule number 0015, Scope and Standards for LPN Protocol Utilization are located. For a bit of background, at the February 21st, 2025 board meeting, the board voted the proposed changes for these rule numbers proceed to administrative rule hearing. Notice of proposed rulemaking was filed with the Secretary of State's office on February 24th, with a public hearing on the proposed rules being held on March 18th, 2025. We received no written testimony on the rules. However, as you have heard on the hearing recording, one RN did provide oral testimony in favor of the proposed changes. I do want to note that the same RN also communicated that she desired criteria concerning reaching out to a prescriber when it is determined by a nurse that an order is no longer safe for their client. Unfortunately, that criteria already exists in a different division. That would be Division 45, Nursing Standards specific to accepting and executing medical orders, whereby it has specific criteria whereby if the order is unsafe, it is unclear, and others items that the RN is directed or the LPN is directed to contact the prescriber or their designee and to come to a decision on how to proceed forward for the safety of the patient. So the proposed Division 49 rules are now presented to you for consideration for permanent adoption. Motion?
I'm guessing we're ready for a motion unless
Okay.
anybody has any questions.
It is moved that the board approve the permanent adoption of OER 851049, Rule number 10, and 85149, Rule number 15, as presented.
So moved.
Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Toabola,
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
Thank you. So that jumps us right into the PR1 agenda item. Are you ready to proceed with that? Okay. So presented for the board's consideration are additional revisions to the draft interpretive statement on practice hours as requested by the board at the February public board meeting. So at that time, the board had directed more work be done to more overtly communicate that the practice of an advanced practice registered nurse is not limited to diagnosing conditions, providing treatment, or prescribing medications. So in address to the request, the draft directs the reader to OER 851055, Rule number 10, APRN scope and standards of practice, where the APRN or another interested party would read it in sections 6, 7, and 8. Under this rule number, we'll find a not all-inclusive list of alternative roles approved for APRN practice that are not limited to diagnosing, treating, and prescribing. So are there any questions concerning the draft or the modifications made?
So I did, and I apologize for not bringing this up in February.
Okay.
Not looking at as close. Well, so I appreciate first off having this interpretive statement out there so we can provide a little more clarity since this issue about practice hours has come up. And maybe this is just my read, so I kind of want to get a little bit of the pulse in the room. With the sort of the practice of nursing that had on the first page 173, their practice of nursing. Just kind of this seems like this is the area where we're defining what to some degree what the practice of nursing is. So we're understanding what the application of the practice hours are. I found this a little hard to follow or long-winded.
Okay.
And I was wondering if anybody else felt that way, or if it would be if if there would be any desire to have, I mean, it describes kind of the scientific process with the practice of nursing, but to have something that was more succinct as to the definition of nursing. And I was kind of approaching it as your average nurse or the lay public viewing this and trying to understand, well, what does a nurse do? And so, I mean, I guess I could read out loud some of what I kind of like turned to what the ANA's definition of what the practice of nursing is, and I don't know if that's as applicable here for this piece, but I think as an interpretive statement, I would want it to be more digestible.
Okay. Yeah, we can definitely go back and look at the ANA definitions and other ones and align those with our statutory definition for the practice of nursing.
Is there any?
I have another question, because this has come up as well. What do you think is the best way for an applicant to demonstrate the 400 hours or the clinical hours when you renew licenses?
I think that would be a question for licensing or someone else. Typically, it's, you know, the RN, the LPN, they are knowledge workers. And the impetus for the statement is a lot of times we'll get questions through the practice box. Well, I haven't been in the hospital, but I've been helping my mom, and I've put in, you know, 3 intravenous catheters. I do bed rotations, this, and this. It's the task, the procedure stuff, and it's disconnected from the cognitive process of application of nursing science, which is the practice that would happen in any setting or role. So that's what we're trying to communicate with this document for those people that have either for whatever reason they don't understand that piece after graduation from the nursing program. So I don't know if that answers your question.
President Cooksey, I guess I don't understand what you're saying with your statement. Can you try to clarify?
Yeah, so when we for the other interpretive statements, I see when one has a question like, oh, what are practice hours? What defines practice hours, right? Presumably, this is an interpretive statement for to Board Member Callis's question. Oh, I'm an LPN and I do care for my grandmother, or you know, I volunteer on the side. Does that count? And then they would turn to this piece. And then when it says under the practice of nursing, the profession recognizes the practice of nursing is rooted in scientific method by applied nurses, the analysis and planning of the response of individual group. For somebody that has like a little bit of graduate education in nursing, I found this harder to follow when someone is going for the question, well, what counts as my nursing hours, right? And that's where I would hope the interpretive statement could be more succinct and more, and it's great that you cite the specifics so everyone knows, okay, I go to that OAR when I want to know the specifics.
Mm-hmm.
I guess I was desiring something that would more focus, that would be a succinct explanation. And I can, like the ONA, like if it's helpful, I could just read out loud what the ANA's statement of the practice of nursing is.
I'm able to follow you, and under your example of taking care of your grandmother, I think that this would say that yes, that was included in the practice of nursing, based on the practice hours are not exclusive to paid practice, based on the scope in the practice of nursing granted with one's license type. Hours of practice of nursing can accrue in a variety of volunteer and non-paid roles, including those identified as above. So, I mean,
Yeah.
you could make an argument that you're volunteering, taking care of your elderly grandparents, providing for their needs, and that could essentially count as practice hours.
Absolutely. I guess what I was pointing out was just trying to make it clearer from the first step. I'm going to read aloud the ANA's definition. Nursing practice encompasses the diverse activities and approaches used by nurses to care for individuals, families, groups, and communities in various settings, both inside and outside of hospitals. For me, that sentence clearly defines for anyone that comes to the interpretive statement, just to start with that piece. And then the details, like as you outline, I think that those can be referenced and pulled.
Can I make a comment? I'm trying to see, I think I get the different perspective. I think where President Cookson might be referring to is after the bracket of that is client. The sentence that goes after that of has to their current states makes it so bulky that if you're reading it through, you kind of get lost after that. Has to their current state of health. If someone just tries to read that and read that part together, it just seems really bulky. But it does cover everything. I don't know if there's a way to break that part into two.
Well, I'm certainly willing to do more work on it to get it more concise and succinct to the best of our abilities.
Thank you.
Policy analysis, I think that we can pull it and take into account what's been said here and go back to the drawing board. If there's any other comments that want to be made, knowing that, or questions from you for direction.
Policy Analyst Cook, I was just wondering, is part of the way that it is written, because I'm assuming we're doing this because there are so many questions. Is part of the reason that it's written this way because of really the nature of those questions? Like as far as like the scientific method, like how it differs a bit from like the scope and standards definition of nursing around prevention of illness and injury and things like that. Is it really focused on those questions of, well, if I'm caring for my grandparents, does that count?
Yeah, I would say to a degree, yes. And I would also say that by trial and error over the last several years, when you respond to those questions, you can direct them to the statutory definition of the practice of nursing, and it is not understood.
Mm-hmm.
So then you try to, okay, how can I hone that in without violating those boundaries to try to explain it a little better, and then we get long-winded. Because, I don't know, on my first day of nursing school, the question posed was, what's the practice of nursing? It's like, okay, for me, it was a 4-year trajectory to get that one nailed down.
Right.
So, yeah, so how do you get that into a paragraph for application purposes? But yeah, we definitely can work on it some more, bring it back in June, and then go from there.
Policy Analyst Cook, it appears that we've been having some issues between the track change and the clean documents.
Are we having the same here?
Well, it would appear so. So on page 180 of our thing, which is, I think, supposed to be the clean program, under the practice of nursing, all of a sudden there's a period between nursing and process, and that is not on the track change document.
Okay. Yeah, I think that's
So there's,
bugs in our Word program, so.
yeah.
Yeah,
Something
Executive
that-
Assistant Brandy Ritter was just mentioning potentially there is, as we transfer to our PDF, that something is happening, so we'll make sure to check that bug.
Yeah.
Thank you.
I'm excited to go back to the drawing board, are you? I actually am. We love
No,
the
it's fun.
challenges here. I think for the purpose though, before we close and move on, I think it's maybe take a moment, especially for the new board members, to really elevate like when and why we use interpretive statements, because the goal is to not use them very often, right? As we're evaluating, what do we have currently, what's old, what can we just archive and get rid of, and then when do we need them? And we want to be real careful when we use them. So I don't know if before we close out to go to the next thing, if you want to maybe speak to that a little bit for our, especially our newer board members.
Yeah, I certainly can. Yeah, we will typically, there were a lot of interpretive statements, or we called policy statements when I first came to the board. And it's usually, they will get written, we have a lot of questions on one topic, or maybe we see a certain practice trend based on disciplinary cases. So we have our statutes, we have our rules. What's the gap there? What's the disconnect that people are not understanding? And so that's when we try to go in without going outside the boundaries of statute. How do you re-articulate that point for someone to be able to apply it to their own practice of nursing without giving them legal advice? but to just give them a better purview so they can apply it, so they can practice safely for the patients and staying within the bounds of statute. So that's why we have those, we call interpretive statements, which do not carry the force of law in the state of Oregon. Some boards, regulatory boards, just have boatloads of statements, very prescriptive, and it's very broad. We have our rules, we have our statutes, and practice happens everywhere. As soon as you have that therapeutic relation established, so the context of care is very greatly, and we want something that can apply in any situation where that therapeutic relationship might occur, whereby the Practice Act applies. These are the things you need to be cognizant of.
I just have an application question, just so and thank you for your definition of the interpreted statements. I do appreciate that. Just going back to that example of, does caring for your grandmother fall under nursing practice with the interpreted statement? If that was the hours that I needed to reapply for my license, would that be something that licensing would accept?
Well, it's going to be case-by-case basis, and it's going to prefaced on how was the engagement in the practice of nursing documented by the applicant. So for the RN, it's going to be nursing process, plan of care, that type of documentation. A little more difficult for an LPN because there's going to have to be a practitioner above them clinically directing their practice. Could be, you know, depending on what it is, it could be hours documented on a calendar. It's going to be a case-by-case. But the thing is that the applicant, the burden rests with them, and it has to be defendable. So if it is questioned or under an audit, what were the key points where that documentation would translate into, yep, that's the practice of nursing. You did these many hours. Yes, you hit that magic 400-hour mark.
Thank you.
Okay. So no motion needed that it's not approved? Okay. Thank you for the comments on that one. So that brings me to my last agenda item on PR2, and this is draft Oregon Administrative Rules for Division 6 Standard Definitions. So respectfully presented to the board are draft revisions to Division 6, and these revisions are presented and they consist of 10 terms spread across 6 rule numbers, and the impetus of these are in support of the changes made to Policy Analyst Blackhurst's revisions to Division 21. And so these draft revisions are presented to you to approve to go to rulemaking, and if so, that is approved, then I would also propose that if it's carried forward, that I have a second motion in the hopper that would permit board staff to go ahead and take the rules to administrative rule hearing. Okay, so first motion is motion that based on the information provided, board staff move forward with rulemaking for OIR 006, rule number 10, rule number 0030, rule number 0060, rule number 0130, rule number 10140, and rule number 0190.
So moved.
Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Tolobola.
Aye.
Rachel Dennis.
Sorry. Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you. So I have a second motion, and that is based on the information provided, board staff move forward to administrative rule hearing for OIR 851006, rule number 10, rule number 0030, rule number 0060, rule number 0130, rule number 0140, rule number 0190, as presented.
So moved.
Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Tolobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
Okay. Thank you, and that completes my agenda items.
Thank you. The next item on our agenda is some pre-licensure education motions by Policy Analyst Blacker.
Yeah. All right, hello again, Mr. President. I'm going to direct the board to page 207 of the packet. There you'll find a memo regarding a request from Tillamook Bay Community College, and it is a request to enroll a third cohort. As I shared in my memo, Tillamook Bay was first approved to admit students in June 2023, and by rule, they may only admit one class until full approval of their program has been granted. The board previously approved Tillamook Bay to admit a second cohort so the program could keep running, and this third request is coming a year later. It is also expected to be the last request because we have that survey for full approval scheduled in the fall. So are there any questions on this item? Right. Then I motion that Tillamook Bay Community College request for a third cohort admission be approved as presented.
So moved.
Second. Been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
Thank you. My second agenda item can be found on page 209 of your packet. So this is a memo regarding a continuing approval survey conducted of Bushnell University's pre-licensure accelerated registered nursing program. As I noted in the memo and survey report, all evaluation standards were found to be met. On this survey, I also wanted to note I was very impressed with the student support evidenced by the program and the university, and the students themselves really were verbal about the support they feel from their program. So my recommendation is to grant continuing approval of this program until June of 2032, which would align our next survey with their next National Nursing Accreditation Survey.
So moved.
Second.
It's been moved and seconded. We'll do a vote.
I didn't actually make the motion yet.
Oh, I'm sorry. I thought that was a motion. Sorry. Never mind.
We're ready to go.
Brain started moving. Sorry.
Great, you're on it today. All right, so let me motion. I motion that Bushnell University's pre-licensure registered nursing education program be granted continuing approval until June 2032.
So moved.
Been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
My third agenda item is on page 231 of the packet. And so this is regarding a board-directed continuing approval survey of Portland Community College's pre-licensure registered nursing program. The board had directed we conduct a continuing approval survey early, and as I shared in my memo, there were several standards that on evaluation I identified them as being partially met or not met. I provided the program with recommendations already on how they could work to address the standards. The three standards I identified as not met were OAR 851, 021, 00459, relating to nursing faculty role and responsibilities, 851, 021, 00453, relating to nursing, faculty-led nursing practice experiences, and 851, 021, 00653, relating to selection of clinical sites. So what I would like to discuss with the board from here is that ORS 678360 requires that institutions that don't meet a standard for approved programs be issued a written notice specifying the defect and a timeline within which they must correct the defect. My evaluation is preliminary. The board is the ultimate authority on whether the standard is actually not met. And so I think the first thing I'd like to discuss is, does the board agree with my evaluation? Are the three standards I identified not met? Do you agree that those are not met?
think we're in agreement. Yeah.
Okay. Any changes? Okay. I'm going to save my motions till the end. Then the next thing I want to confirm with the board is that in issuing this written notice to the program, that you would like to delegate the preparation, signing, and issuance of that notice to myself and Director Prusak. The next thing I'll need the board to affirm is a timeline that you would like PCC to correct the unmet standards. So in my report, I proposed 6 months. Again, you are the ultimate authority. I would recommend that you can always give the program more time. I would not give them less time, simply because they have a summer break coming up and there is work needing done. So is 6 months appropriate, or would you like a different time frame? Yeah, it would be middle of fall.
Yeah, I think that's reasonable. I think this is
Okay.
what you've highlighted is some of the ongoing issues that I know that they're working to address. So
Okay, yeah.
that's reasonable.
Then, before I make my last motion, the other item I want to reaffirm with the board is that I do recommend continuing approval of this program. They are continuing to evidence good student outcomes, regardless of their challenges. And so my recommendation here would be that we grant continuing approval through June of 2027, and that our next survey occur in alignment with their accreditation survey. Okay. All right, then I think I've got a motion for each one of these things. All right.
Unless there's any board members have any, we're ready for the motion.
Okay. Then my first motion is that Portland Community College's pre-licensure registered nursing program be issued notice of deficiency related to OAR 851-021-00459, 851-021-00413, and 851-021-00653 as described in the February survey report.
So moved.
Second. It's been moved and seconded. Let's do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
Next, I motion that the preparation, signing, and issuance of Portland Community College's written notice of deficiencies be delegated to Policy Analyst Laura Blackhurst and Executive Director Rachel Prusak.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
Okay. For my third motion, I motion that the Portland Community College pre-licensure registered nursing education program be required to submit a written report providing evidence that the deficiencies have been corrected within 6 months of the notice.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion has passed.
My final motion is that the Portland Community College pre-licensure registered nursing education program be granted continuing approval until June of 2027.
So moved.
Second.
Okay, sorry. I'm just, a question here. Should we be contingent on the corrections, or does it? I don't know.
I think there is a process for if they do not meet the corrections in 6 months.
You would go back to the board, you would come back to the
I would
board.
be, so we don't do any contingents. Okay, I apologize for
No,
stopping that
thank you.
process.
We would
Thank
have
you
the
for
process
clarifying.
follow up then. No, it's good to clarify that.
Yeah, it was a great question.
Do you want me to remake that motion?
Please, from
Okay.
the get-go.
Then I motion that the Portland Community College pre-licensure registered nursing education program be granted continuing approval until June 2027.
So moved. Second.
Been moved and seconded. We'll do a vote. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Toabola,
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Okay, thank you. That was all for that agenda item. My fourth agenda item today can be found on page 269 of your packet. This is a memo in regards to a continuing approval survey conducted of Clackamas Community College's pre-licensure registered nursing program. As I noted in this memo and survey report, all evaluation standards were found to be met or partially met, and for the partially met items, I again provided recommendations to the program on how to improve. This survey, I wanted to note that the 2 clinical sites we toured very specifically were so excited to have Clackamas students at them. It was very apparent on the survey. And then I also just wanted to publicly commend by name Beth Doyle, who has been very committed and invested into the success of the nursing program. My recommendation here is to grant continuing approval until June 2028, again aligning with their National Nursing Accreditation Survey.
We're ready for the motion.
Okay. Then on this one, I motion that the Clackamas Community College pre-licensure registered nursing education program be granted continuing approval until June 2028.
So moved.
Second. It's been moved and seconded. We'll do a vote. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Toabola,
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
All right, my fifth agenda item for you is on page 292 of your packet. This is a memo regarding a preliminary application for a new pre-licensure registered nursing program from Carrington College. In my memo, I provided some background information that Carrington College used to be approved to offer pre-licensure practical nursing education in Oregon. The program continues to operate out of a Portland campus, and so this is representing bringing back registered nursing as an offering. The application contained all the required components. We did receive 5 letters of concern from Oregon nursing programs, and in summary, the concerns were around the availability of clinical placements and competition for clinical sites. Carrington College did include in their application the evidence of how they have followed up and interacted with those concerned nurse administrators, and they also included 9 letters of some support from local healthcare systems and agencies expressing their support and willingness to take Carrington students. Are there any questions about this item?
Well, I would just like to note there were multiple letters, and it seemed like it was a form letter that they signed. And I guess my biggest concern is that when we keep seeing these and we hear from our current programs that they are having extreme difficulty with finding clinical placements, yet when in the letters that we received about this letter of, when they sent the letter of intent, and yet we keep having our practice partners say, yes, we would be happy to. I'm wondering if can we ask our practice partners to make some sort of a commitment to the number of students that they will take? Because when we get down to it, what ends up happening is our whatever students we have get fewer and fewer hours as these practice partners try to accommodate more and more students. And I think that limits our ability to have quality education and have quality nurses graduated. So I'm just concerned. My question is, would we ever not accept a program? Or does it take the practice partners having no letters from practice partners?
I do think that, there's always a potential the board might not accept a program. if, based on their application, you were concerned about the program being proposed. I think the challenge with the clinical placements, especially at this stage, is that for the preliminary application that's going to the board, this is their preliminary application. They can't actually formalize clinical placements at this point, and so we can't ask them for evidence of that at this point. I think later in the application process, before they admit students, that is something where, before you admit students, you've got to have these relationships more formally established. And I think we do include some of that in the revisions we've been looking at to Division 21.
So, I appreciate you thinking about this, or policy analyst Deckers, because I think that these things go together. So if with the new Division 21 rules, where there will just be there's like a developmental letter, which will kind of be this, and then there will be this initial approval. So it's prior to that initial approval, could we make some sort of requirement that they have letters stating that they will be able to get the number of clinical placements from the partners that they identify? So I think that is, because I think it's really easy to say, yeah, we'll take some students, thinking we'll provide placements for 2 students when they have 32 that they need to place.
Yeah. So I actually have a great response to this. So the Division 21 changes we just discussed in the proposed step 2, prior to this initial approval for admissions of students, we do require evidence of adequate clinical placements for the program with supporting documentation.
So we as the board can say, we need to know how many placements, because what we've seen in the past is just, we enthusiastically endorse this, we want more nurses, but no commitment really from practice partners. And practice partners they do need more nurses, they do want to support nursing education. It's just that there are, it's like a step removed. And so getting that commitment to, we will place this many students in our site, I think would be helpful for us as a board to determine, is this going to affect the quality of experiences that all nursing students in our programs get?
I think as the board evaluates applications, and again, future applications when they get closer to admitting students, I think it's within your purview to look at the evidence being provided and determine if it's sufficient enough.
I'm firmly in support of Board Member McKinley-Yoder's comments, because when I saw this, I feel like we've heard so much about the lack of clinical placements that when I saw just yet another program wanting to come into the Portland area, I had major concerns about our ability to accommodate them.
I think one of the conversations that we are having across the state, again, is OSBN's role in regulating clinical placements themselves. And one of the challenges are, like, these are truly agreements between the nursing programs and the site. And so, yes, nursing programs have to have clinical placements. That's a resource we expect programs to have, but we can't necessarily get in the middle of that affiliation agreement.
Just a clarifying question. So we approve the number of students. So is it that far of a stretch to also have the number of clinical sites available in the letters of support? And we're approving them for 32, and I think with what Board Member McKinley-Yoder was saying, that I don't know if that's, since we're approving the number of students, is that much of an ask for them to tell in their letters of support to them also to show how many sites that, or how many placements they're dedicating?
I guess I have 2 thoughts on this one. Is if it's an expectation of specifically what you want to see, we should probably codify that more in the rules. And my other thought is, when a new program is approved, typically they are presenting information about how many students they're planning to accept, how often. However, again, some of our changes in Division 21 are moving away from making programs get approval for every time they admit more students. And so the initial approval that we might grant might be for 32 students, but that would be the last point at which we're regulating the number of students for the program.
Yeah, and I think if I could jump in and try to refocus back to the what we're talking about at hand, but really elevate that these conversations are happening across the state, as mentioned earlier, across every state. Since COVID and after COVID, there's a struggle. And I think there is something I say that isn't very loved when I say it in the spaces, whether it's deans or directors or Division 21 or now here. But when I'm in conversations around this, it truly is for our schools and our clinical practice sites to really come together and solve this issue. Can the board somehow be a part of those solutions? Yes. But where do we and how do we regulate? I think is a really distinct line, and that we need to be careful as we have this discussion, because it is. And there's no denying that there aren't challenges at hand, but I just think that at this point in time, what happens is a school gets approved. Many of the students are from Oregon. They didn't get into another school for many reasons because of this lack. They stay as nurses. We have to figure out how to continue to support that and support the workforce and allow them to continue to be creative. And if there does end up being space, isn't it when their surveys are being done and then you learn these, right? So I think we just have to be careful about where this conversation goes and understanding what our role is. If there is something that somebody on the board wants us to come back in June and present to you, I'm sure policy analyst Blackhurst could dig into it and come back and say, this is what I found in that space.
I would be interested in hearing that. I'd be interested in hearing just from the clinical sites and from the students really about clinical or maybe quantify the problem of clinical sites, because obviously there were the 5 letters of concern by the educational programs saying that they're.
But at this stage, we wouldn't hear about the clinical placements. That will be the next stage of their application.
Right. So
that'll be down the line. I want to turn to Board Member Callis because she's been waiting very patiently.
So just wanting to join the discussion. And this program in particular, they feel that this program is going to help solve the shortage of nurses in rural and underserved areas. So that to me says that they would be looking for clinical sites in rural and underserved areas because, right, that's where they're going to try to send their nurses. So, I mean, I think that should be part of the discussion too. If that's part of your mission, let's see some action.
And I also want to highlight the nurse administrator is here, Candace Bethany, I believe a newly appointed nurse administrator. And so if you do have like direct questions about these partnerships, she may be better suited to answer than I am.
You want to
have
come up
you,
to the
yeah, and just introduce
table and
yourself. Yeah.
introduce yourself, and before you even do that, press the button on the mic, and when it's green, you're ready to go.
Thank you, Mr. President.
All right. My name is Candace Bethany. Thank you, Board President Marcus and everyone else here, all the board members and poly analysts for having us here. Candace Bethany, and I am the appointed dean for the Portland campus for the nursing program. And just to kind of address some of the concerns that you have in regards to clinical placement, we sent many letters out to the programs, to the schools, and also to clinical sites. Within the schools, we sent approximately 30, and we received about 5 replies. 2 of the replies that we did send were about 200 miles away from our campus that is here in Portland. So definitely not looking to, misplace students in anybody's facilities, but those are places that were far out from where our facility is. So I just wanted to address that as well. And then the letters that we received of intent, definitely we sent out 60 different letters out to the different nursing nursing officers and executives of the different systems to get support. And at that time that we put this together, we received about 9 intents of support for our students being clinically placed there.
At any time, was that quantified in the number of placements these sites will commit to you?
To my knowledge, the number of students that they would actually place was not specified.
I have a question about the letters of intent. And this could just be that it's a standard thing and I'm, newer at this. But it seemed like a lot of them were worded exactly the same, even like, and I was kind of interesting, the OHSU, theirs doesn't even, like, it says it'll be a great benefit to Carrington College and facility name instead of actually their name. Is that like a standard thing that they're just kind of a standard form or whatever? I'm not sure.
I also have online as well. I don't know if Dr. Summer is able to speak as well. She's our associate provost. Should be available to answer questions. She might want to speak to that one.
Good afternoon. Hi, I'm Dr. Karen Summer, and I'm the Associate Provost for Nursing for Carrington College. And yes, you're correct. It is a standard form letter that we use when we are inviting our clinical partners to respond to us. So you're correct in that. And no, they don't put a number of students, because at this point in the process, we did not ask them to confirm the number of students. Because as stated previously, that's in the next step, right? When we make our agreements with them. And so we didn't feel that that was a required item to include in those letters.
If I may interject,
Mm-hmm.
This is, again, the program's preliminary application.
Yeah.
So they have not yet really developed out a curriculum or courses. And so I can imagine for the program, it would be incredibly hard for them to even forecast what sites they need from what partners. It's just too early in the process for them to really have that, because they don't have any level of approval from OSBN yet.
And if I can add another piece in the next step, when you do have feedback and we have more information and you have your clinical placements, there's also, the board has the authority to limit the number of students entering, right? So if the number of placements doesn't look isn't proportionate to the number of hours available, that would still be an option.
I believe in the approval phases, yes, you could limit admissions or enrollment, but then later, once the program has full approval, the updated rules in Division 21 were no longer regulating admissions and enrollment.
I bring that up to try to allay some of the concerns of the other board members, that there are other options to adjust, at least in this, thank you for that, at least in this preliminary time, as a school would be getting up and running. Any other questions?
I think what everyone's just kind of expressing is just how important maybe we are going forward, aligning, having the clinical part of it, along with saying, okay, yeah, you get 20 students to be at the school. That's great. You're going to get all that money and all those things. But at the same time, are you going to have the clinical hours instead of those students scrambling? I can speak to that myself. I do know that some of my cohorts actually did have to look for their own clinical hours, and some were like 2 hours away from where they were at. So it is very complicated, and I can see why this is such an important thing and why we keep bringing it up, and echoing the same sentiment.
Yeah, and I think I'll just, put a point on it one more time, is that every state is struggling with the figuring it out, and I've heard some real horror stories, absolutely. And in this space for what we do, great to have a discussion around it. but in a preliminary phase, how much of that is needed to know, and as we move forward, those discussions can be had. And then again, what is our role and what is the state's role and what is faculty's role, and really defining that. And I think that's something that policy analyst Blackhurst and I can come to June and really put a finer point on.
Any other questions?
I think we're ready for the motion. Thank you.
Then I motion that Carrington College's preliminary application for a pre-licensure registered nursing program be approved as presented.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Toowobola,
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Nay.
The motion is
All right. Then my final agenda item today is on page 377 of the packet. Here you will find a memo regarding a decrease in admissions at Rogue Community College. This item does not require any board action or vote. It's informational only. However, Rogue Community College made a difficult decision to not admit a cohort of students due to both challenges with clinical sites, but also clinical faculty. From the materials they submitted, I do want to highlight Rogue's support that they are providing to their students who are impacted by this decision, including covering tuition costs for a term. And since they've made this decision, the nurse administrator has shared the positive impact it's had in the community, and now that everyone is very aware and interested in supporting the program to get future clinical sites and clinical faculty. So again, this is just for board awareness. No action is needed.
thank you.
Great. Thank you, policy analyst Blackhurst. Our executive director Prusak, are you ready for your, do we need to pause or?
I'd like a break.
Yeah, I think we could use a little refresher. How about at 11:35? All right, we have our last item before lunch from Executive Director Prusak. 2 items, looks like.
Good afternoon, members of the board. It's always great to be the person keeping you from lunch. But here goes. So I'm just coming to you with 3 items. One, if it's okay, I'd like to go out of order because one, the A2 has no motion, and I am just kind of winging it to give you brief updates to let you know how things are going along. So we've been having really great conversations about Health Professional Service Program and re-engaging in it. We are still really on target to hopefully, when we see each other in June, make it official. The RFP process is in its final stage. So I'm really excited about that. Oregon Medical Board, my director, myself, and Board of Pharmacy director are engaged and will be moving forward. So I hope to still be on target and come to you in June. And compliance specialists, myself, and investigations manager in Paris are still hard at work updating our policies and procedures internally, some that we have brought before the board. The other really exciting thing is the attestation model. I can't tell you what this feels like to have had Lorna Breen Foundation come and present to you all, come forward with an attestation model that you all said, this one's challenging, go back to the drawing board, make it better, came back to you all with an attestation model. From there, then Division 31 was voted on, and with Division 31 work, our licensing manager worked with our data provider that manages our licensing to update those applications. And so big shout out to our licensing manager, Philip Fox, for doing that final stage for all of us, getting that done. So I presented to about over 200 nurses, community-based care nurses, a couple of weeks ago, and then tomorrow I'm presenting to the Oregon School Nurses Association. There'll probably be about 200 nurses, and in that presentation, to be able to say the mission includes nurse wellness as public protection, that the Oregon State Board of Nursing lives by this, by one, removing stigma. And how did we do that? We removed those intrusive questions, have an attestation, and it is live now. And the day that it went live, I kind of wanted to like stand up and scream and celebrate. I'm like, who wants to hear this? Who wants to know this? It will be, in our newsletters. It will be in the Sentinel article that comes out next. Everyone that's in my circle has heard me talk about this, and it's a big deal, and it is something that the state boards will follow. Currently, the medical board and us, and then boards across the nation are following. So pretty big deal. So just wanted to really thank you for all your hard work, walking alongside me with that process over the last year and a half, and that is officially done. And then the final update, National Council State Board of Nursing, I attended a conference. It was really great to connect with the executive officers from across the nation. We did a lot of discussions. A whole day of presentations revolved around alternative discipline programs and mental health and mental wellness. And that included panel discussions with boards and those in alternative discipline program leadership, as well as a psychologist on addiction. And the second day was a lot about the challenges in academia and the challenges in our workforce, and that includes clinical placement. And so it was interesting discussions had all around. Next week I'll be at a conference for the Physicians Alternative to Discipline Program in Seattle. And next month, the board president will be joining me, and we will be going to National Organization Alternative Programs Conference, which we went to last year. So really looking forward to continuing all of those discussions. So out of those brief updates, do you have any questions, comments, concerns?
Dr. Prusak, I think you mentioned it earlier, so you regarding the clinical placements, that's a nationwide concern. And are most boards of nursing finding that it's not, are they determining that it's sort of outside of their purview?
Yeah, I think what will be best is if I really come in June prepared to give a presentation on this. And I do know that with Oregon Center of Nursing presenting in the afternoon, while it wasn't the main topic of discussion since she's been here all morning, she will address it. But I think coming back in June to really do that. But ultimately, while it isn't within the Board of Nursing regulatory standards, there are ways that you engage in the conversations. So I think it'll be really great to come back in June. I'm up for the task, so look forward to that. Okay. Then let's move into A1, basically on page 385. This is continuing on the discussion really about monitoring behavioral health and cognitive physical impairment. So I am respectfully requesting a motion from the board to open Oregon Administrative Rules, Chapter 851, Division 070 of the Nurse Practice Act for rulemaking. Division 70 contains standards related to the Alternative Discipline Program for healthcare providers, i.e. our Health Professional Service Program, HPSP, and standards related to the board order discipline that includes the monitoring of behavioral health and cognitive or physical impairment. Updates to Division 70 OARs are necessary with the board's reentry into HPSP and focus on promoting wellness for our nursing professionals. If the proposed board motion is carried, thus opening Division 70 for rulemaking, a Rules Advisory Committee will be convened to collect feedback on draft rule language and to collect information on the fiscal impact of the draft rules and on how the draft rules impact equity in this state. So this will be that final kind of piece needed. In June, we adopt, and yes, they can reenter again because that was removed for self-referral. And I feel like I'm looking at you, Board Member Hill, because we started around the same time and we were having discussions around this topic and looking forward to the day that there may be a Rule Advisory Committee. So here we are. Any questions or comments or concerns on that one? Yes.
It may not be in this, but I know that we've talked many times on the financial burden that obviously somebody has to endure in that. Is that something that will open up in this with testing and the coverage, or is that not anything?
So it can be something that's discussed. It wouldn't be something that's going to happen by the very first step. So that we don't delay reentry and self-referrals. I will say, attending these conferences and meeting with experts on this, once again, it's the way that it is worked across the nation that people are paying for their own testing. Is it still a barrier for some? Yes. But is it an issue across the country? Yes, not just here. One of the things that I'm hoping to continue the conversation on once we get to the next spot is, where does somebody's health insurer come into place? Where does the potential for partnerships with the systems offering their labs, which would cut down prices? So I just have to get through this step, and then I really look forward to those conversations. I just don't want it to preclude us from getting in.
If I can add,
Yeah.
I think really when we look at the models of what other states have done for alternative to discipline, the real challenge we have in Oregon, partly, is that we oversee this variety of licensure and certificate holders, right? And so, and we obviously, we desire to have a system that covers CNAs, LPNs, and RNs. However, when we look at other systems that make the alternative discipline work, the wages that a CNA pulls in for them to participate is just vastly different than what an RN pulls in. And so then that model doesn't work. The one-size-fits-all sort of model becomes untenable for a CNA to work in. And so that's where we're going to have a lot more discussions. You highlight it appropriately, and there's not going to be an easy answer. I think as we learned from the conference and meeting with a lot of experts and folks that run these programs nationally, there are good blueprints for things we can follow that we could be able to expand and look at the CNA's involvement, but it's going to take a lot more legwork and partnership, and maybe a little changing to what our expectations are. But I think that's going to be a lot of what we talk about in June.
Yeah.
And beyond, and beyond.
And beyond.
Because as we've seen with every month, we're like, there's somebody that would be appropriate for alternative discipline, and unfortunately, we're putting our staff towards that. So,
with opening up the rulemaking, would we be able to, I know that in the previous discussion, we talked about the civil penalties just kind of going into the general fund. Would it be a potential to kind of earmark some scholarships for people in financial need to go into this program?
Those are the things that we can get creative on. I just don't know what levers we can pull, but I promise you that I'm up for figuring that out. And what I'm most thankful for is this board. You all have had really great discussions about this topic, and I've had the opportunity to learn from across the country. Your board president is learning also. I'll bring everything that I can to you all to continue updating you, but that is the goal, is to just figure out where, how, when. But to touch on the point about CNAs, so in some states, CNAs are not on the umbrella of the Board of Nursing. They're in the umbrella of Hair Department of Health. I'm very thankful that Oregon is one of the boards of nursing that does have them looped in, but it does, pose how it does change and where CNAs weren't involved and engaged. But I'm going to continue to challenge that as long as you all put me up to that challenge. Should I make a motion? All right. So I make a motion that based on the information provided, board staff move forward with rulemaking for OAR 851-070-0010, 851-070-0025, 851-070-0060, 851-070-0070, 851-070-0075, 851-070-0080, 851-070-0090, and 851-070-0100.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nestel.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Great. Well, I will move into the last piece for discussion before lunch. And I'm looking forward to this, and I'd like to invite Investigation Manager Erin Ferris up to help guide discussion, as I have a feeling there may be questions, comments, concerns that she can really help me with. But if I can draw your attention to page 386. So as you all know, virtual board meetings have been held bi-monthly to ensure board members address any urgent matters between our regularly scheduled 2-day board meetings held 5 times a year. And a more common practice is for boards to call a special meeting to address urgent public safety and regulation needs when necessary. And at the Oregon State Board of Nursing, working to uphold our mission to protect the public, we're continually looking for ways to evaluate and best utilize resources. So by hosting fewer meetings, we may allow more time for thorough, focused work, which not only enhances the quality and comprehensiveness of the board's investigative efforts and reports, but also supports public safety and the health and wellness of our workforce, our board members, our staff. So I just really wanted to bring that discussion to you all. I think, there's been a challenge of continually working to produce board reports every month. And we have a lot. And I have kind of reached out across the nation and to find out really how board meetings are run through boards of nursing, because we have a lot more licensees than other boards, whether it be physical therapy or the medical board. And it really is those, 5 to 6 times a year. I kind of looked back historically about how this may have happened here. And in 2007, there was a backlog of cases. And so the executive director at that time made a decision to have meetings every month. And they were on the phone then. It was pre-COVID and everybody was comfortable at virtual meetings. And so that's how it was up until COVID. And then during COVID, every meeting was virtual. And so every meeting had all of the cases that we kind of discussed. And then as I, came in and just constantly looking for different ways to ensure efficiency for everyone in the process, our licensees, our board staff, and our board members, and our investigative manager who reads them all. I just wanted to bring this forward to you do we need to continue that? And are there other ideas around our board meeting schedule and potential efficiencies in between? I feel like I kind of lost track on, so let me backtrack. During COVID, every meeting was virtual, so every meeting, everything was discussed. And we've kind of, made sure that we've had brief meetings in our virtual evenings for good reason. Most of everybody works during the day, and there's only so much discussions we can have. Anyhow, open to discussion. I think I just want to remind the board we're in public meeting as we have these discussions, so being careful of what we talk about, but would love to have different ideas and questions about this. I don't know if there's anything you want to add or questions.
I would like to say something first off that I really appreciate Manager Ferris and the work that you've done in the time that I've been here. I've really seen the quality of the investigations and the print up of those improve, and I think that's in no small part to your hard work. I would like to ask you how the month-to-month, doing a meeting nearly every month, how that sort of that process is going for you, and where you feel that there could be more efficiencies to changing the board meeting frequency.
Thank you, Board President, members of the board. Currently, the process that unfolds kind of behind the curtain at the Board of Nursing when we're processing board reports and investigations, soon after we conclude a board meeting, investigators immediately start producing the board reports for the following board meeting. It's almost immediate. So they do post-board work the day after the board meeting, maybe even the following business day. And that next week, they have the due date for those board reports for the next meeting. So we're in this constant hurry up and figure it out in terms of evaluating the work. So if we have, for instance, in our in-person meetings, we see a full agenda, whereas in our virtual meetings, we see kind of an amended agenda. During the in-person meetings, I will review ahead of time upwards of 100 plus investigations. And because of the short timelines involved in that process, it doesn't allow for some of the feedback to be memorialized. So it doesn't lead to consistent feedback to the investigators, quite frankly. And when we're talking about equity and considering a fair and equitable process, not only for the respondents and the people that we're actively investigating, but we're talking about making sure that the information that you receive for your very important decision is comprehensive, that short timeline really impacts the ability for the investigative manager and the investigator to do a deep dive into the context that they collected during the investigative process. So quite frankly, it doesn't allow for a in-depth full case review that would be essential and appropriate in these circumstances. So every month we're in this quick turnaround feedback cycle, and it doesn't allow for the investigators to budget their time appropriately so that they can make sure that things are as comprehensive as they should be before coming to the board, quite frankly.
Licensing Manager Affairs, I'm wondering, just because I know, like, and you know this too, that, and I'm sure your investigators and you feel it all the time, that a lot of the disciplinary cases can be very heavy. And so I'm curious how many additional cases you think that the board would see every 2 months, because we do have this one day, and it's frankly exhausting. And my concern is that, like, as humans, we want to give the most thoughtful deliberations. And so if it's too much all in one day, that would be my biggest concern. And maybe we could reorient things so we had 2 half public days or something and 2 half discipline days. But anyway, so I'm just curious, what's the additional, do you think?
When evaluating the current board structure, current board meeting structure, the virtual meetings, generally we see anywhere from 30 to 50 cases. Some of those being brought back in front of the board have already been reviewed by the board. So just require those finalizing points, which I think we could explore delegations for, so that potentially the board wouldn't need to see them again in order for them to be finalized. So in effect, I don't know that it would be a dramatic addition to the number that you currently see. I think anywhere from 30 to 50 additional cases, dependent on if we do find space for some of those additional delegations. And also in evaluating how much time those virtual meetings have been taking in general. It's about an hour, hour and a half, maybe 2 at most. So I think we're looking at potentially an additional 2 hours to what we're doing now. And then we've also had this creative idea of turning the agenda around and reviewing some of the more complex cases initially, as opposed to leaving those for the end of the day while we're all very tired and exhausted and we've made these very complex decisions and had these very in-depth conversations. I think that will also serve this process.
And I think that if I could add just about time, we get out very early often on Thursdays. We could always start Thursday mornings with some of the very end and other motions, public motions, or other stuff.
That would be a good option. Also, just thinking of preparing for the vote, and that we pivot from this whirlwind to the public voting. That could be a good option to reserve some time on the second day, on the Thursday morning, if you will.
I think one of my, we're all thinking about ourselves, but one of my concerns is just, it's a lot of time to prepare how we do it now. So if we've got another, I don't know how many cases additionally, that would be challenging, very challenging to get this information read in the 11 days that we get to prepare for this.
Yeah, I can throw some stuff out there, and then if I miss something, one of the things I know as we prepare our large folder to send to you all, and then sometimes you get addendums, sometimes it's executive session and sometimes public. How can we improve that internal between? Will allow that, and also potentially allow, instead of 2 weeks before, 3 weeks before, giving you a whole nother week. I think that would really free up for that potential. So, 1 month without all reading, and then the next month, yes, some additional, but another week to prepare because we have that time. And going back to what are those potential delegations that the board can give us, and there won't be the ones that, maybe not need to be before you. And that is a trend across the nation and other boards in a state.
Can you give me an example of what a potential delegation would look like?
Yeah. Do you want to start? Or do you want me to throw it?
I'd be happy to. Yeah. In the circumstances where the board has considered a case for a stipulated order and they've already reviewed the tenets of the case and potentially even the tenets of the language within the stipulated order, we bring those back to be adopted. A delegation potentially for us to finalize those once they're signed and received by the board, instead of bringing them back in front of the board. Or the other one that in my mind's eye, would be default final orders, a delegation for us to accept a default on a final order where the board has already seen the tenets of the case, asked us to issue a notice, and the timeline has since gone by for the respondent to respond to that notice, and us having a delegation to finalize those cases without bringing them back in front of the board.
And maybe delegation for amended notices, that one too. So those three are the ones that think of off the top of our heads.
Okay, and just so since I'm a new member, when we give you a stipulated order, there's a negotiation between the investigator and the person that they're contacting. So that whatever the results of that negotiation won't come back to the board. There'll be a delegation to handle that. Is that what you're saying?
If there was no changes, if it was the board ordered it, it was agreed upon, there was no changes, because right now those come back and you got, hey, remember that thing you did? You still support it? That, if there were any changes, there would have to be a different delegated order or come back.
Okay.
Maybe you can
Thank
speak
for
to it a little bit
clarifying.
more eloquently than I.
We can plan for making sure that the board can review the language of the stipulated order prior to seeking the signature, and then with the appropriate delegation in place, we could finalize that in amongst the staff as opposed to bringing it back to be adopted. But you would be aware once more of, one, the facts of the case, but two, the language that we intended to put in the stipulated order. There is already a delegation in place for the board to negotiate those stipulated orders.
Yeah, I mean, one of the goals of doing this we don't want to delay anybody receiving anything final. We don't want to delay the work that you do, and we definitely don't want to delay any of the work we do. So I think there's a way to do both.
Potential to work smarter rather than just harder, and to get those timelines shorter for resolution for the licensees. I'm curious about the process Board Member Mitchell brought up. So then if the board were to have a majority that wanted to direct a stipulation, right, then we would vote on it at that time, even though it's a direction, or would it still be, that still would have to be negotiated and then brought back?
We can look into it.
Okay, it might require more.
Yeah, I think we're hearing some discussion from the board. I think what would be most helpful here is for us to sort of go back and take a look and see what the different options are, rather than trying to make any, sort of off the cuff predictions at this point. But
Okay.
we hear what you're saying.
Yeah, so there's a menu of possibilities of how we could work, I think, smarter and not just harder, and we could timelines.
And I will say a large part of our full agenda currently is adopting those stipulated orders.
Sometimes we have cases too that, we've spent time reviewing and reading, and then they get pulled really at the last minute. Do you think this additional time would help with that?
Absolutely. I think that's actually, in effect, what you're seeing is trying to fit in a lot of potential feedback in a short timeline, and trying to make sure that that feedback was not only captured by the investigator, but then demonstrated in the board report. It also builds in this additional space and time for investigative management, as well as our legal counsel, as well as our executive director, to look at the finalized packet before it is actually produced to the board. At this point in time, that is not a step that we have time for. So when you see the finalized packet, is actually the same time us as management see the finalized packet.
So, if I'm understanding you correctly, the proposal is to just continue with the 5 in-person meetings a year, and then have then kind of like a as-needed meeting, if we need to meet urgently.
Yeah, so prior to 2007, that is what it was. That is what it is on most boards of nursing. So at any time needed, there's something urgent, we are always able to do that. We are now able to do that too, despite it. But then is there an opportunity to also look at next year's schedule? So it is 6 times, so you don't have those 2 months off in between, because that's something I know I've been thinking about too.
So address the concern of like, oh, we're just pushing the extra 30 to 50 cases from a virtual. Well, if we add 2 days, I think it will even out and be more efficient.
I also am concerned about scheduling. It's nice to kind of have the meetings, so I can make sure that I'm not working and have the time off.
Said, looking at this proposal here, specifically kind of removing the virtual meetings. The two that I had issue with is when we have a 3-month gap of the in-person meetings and so that's August and December's meetings.
Mhm.
I wonder how we would feel about keeping those to make sure that we're not holding up anything that does require board votes.
Can I chip in on that? Because I think I was kind of heading towards there for like the potential urgent special meetings. Would it be appropriate to put a tentative on one of those dates as a potential special urgent meeting? And then if that's not going to happen, we get notification ahead of time, like that date that is held will not happen anymore.
So a way to make sure your schedules are reflected, and then if you're granted time back, you're happy. But it's held on there. Yeah, I was thinking about that too, so I'm glad you brought it up. And if that's something that you all want, just direct me to do that. And then do you have thoughts?
I was just thinking about the difference of calling it a special meeting, because I know that there are
Yeah.
certain public meetings, notifications and such that we would have to do, but
Just keep it as it
like
is.
keep it as the current virtual meetings and canceling if otherwise not needed.
Basically, it just like in bracket, like if needed, we hold it. So then we all know like it's not guaranteed. It's just if it's needed, we'll have that date. Yes.
Because honestly, I feel like trying to schedule everyone,
Yeah.
I mean, I think many people, yeah, it would be a nightmare to try to schedule a special meeting.
I had that same reaction to the special meeting. I was like, how is
Yeah.
that gonna work?
If I ever had to call one, it would be, we just had to have a quorum, so we would need 5 of you. So if for some reason there needed to be some type of order that we weren't able to do without the board order, that's when it would be done. And 5 of you would have to be able to attend if that happens. But I'm very open to leaving August and December now and then thinking on what 2026 looks like as early as possible, because everyone's schedule is busy, and is that every other month. So there's 6 meetings instead of 5 meetings, and you don't have to worry about those 2 times where there's 2 months in between.
So how do the other board members feel about switching to every 2 months for 2026?
Every other month,
Every other month.
so that there's 6 and not 5.
So start in February and then go out from there.
Yeah.
And
And
we
then-
would be good to do that based on the public meeting laws, that there's plenty of time. Okay.
Yeah, because that's what we do in preparing for this. So anytime you all bring something up and I'm like, hold up, just tell me and I'll come back, so that then we post it. It's, what is it, 10 days, 20 days? I don't remember, but. And canceling. Oh, are we in time for May? We must have been, or you wouldn't have let me do this.
We'd be looking at May 26th, February, sorry, February, April, June, August, October, December.
Yes.
If we go with that, we would just be adding on possibly about 2+ hours to our usual day on that first day?
I think it depends, and then you can add on, but I think it depends. I think it's how this works, how much stuff you ask me to look into for delegation that won't even be on the docket, how we organize our days, flipping the script like we did yesterday, and then potentially having the Thursday morning for the final motion or other things. And then, so maybe, not, who knows, maybe 1 hour, maybe 1 hour and 20 minutes. I don't know, but I think it's an opportunity.
Well, one, I wanted to say thank you, because when I read everything, it really is well put together. It makes my job that much easier. That I have to say, even though sometimes my head hurts by the amount. But I have to say it just really keeps me on track of how organized it is. The other thing is, it may fly by a little bit quicker. Now, I know we don't always, but on those cases that are obviously dismissal or dismissal with letter of concern, it seems like we go quicker on those too. And I know there's no way to juggle that in a month of what you're looking at. How many do we get of those that are recommendations and how many we don't that are probably others? That's just a thought too.
I think we've explored some of that about how do we find some of those simpler or more straightforward, not simple, this work is very complex, as you all know. Your decisions are very complex as well. But the ones that are more straightforward and or clear in the facts pattern that they point toward dismissal, I think when we have caseloads that we are facing, such as we are facing now, over 100 cases per investigator, it is hard to actively work all of those simultaneously to immediately identify what might be a dismissal versus what might actually be something that we might be in a position to ask the board to consider a disciplinary action. So that makes it tough, but I just wanted to give you that additional context. Yeah.
Just throwing us out here, you know, I wonder if there's a way to, like, thinking about the consent agenda, is there a way to divide the work?
Yeah, I think you're referring to sometimes how some boards do kind of committees designated. I think there's potential for us. I have to look at our statutes and understand how this board is set up, what that would look like. So I'm committed to looking into it. So potentially something for next year. I just don't know where. But I do want to look into that. It is interesting when you come together with all the boards across the country, you know, some are 7, some are 11, some are 13, some meet, you know, this way, some have those committees. I think there's an opportunity to explore what we can do.
Actually, just to the board members, my only concern, I so appreciate all of this. My concern about next year, if we're going, you know, starting in February and going through December, is people's availability for 2 days in December. That is, do people think they would be available for a 2-day meeting? Or just maybe one? It would be a 2-day meeting.
Yeah.
So I want to call that forward if we're starting in February and we're doing every other month. That, or do we start in January and end in November?
I mean, there needs to be 5 of you. So.
and Joni.
It's up, I mean, you guys can figure this out now.
The 2 of you.
One of the 2 of us.
Yes, and one of the 2 of you.
But why not start it in January instead of February?
I'm open to whatever you.
January the 1 rather than.
Oh, but you worry about, yeah, actually.
I will give you some insight to the experience this last January. Due to staff wellness as well, which is something that we're absolutely considering when we're considering this request to the board. It was really difficult to turn out a board packet this last year because of leave, because of wanting to support people and taking time off to spend time with their families and loved ones. So that was actually the month that proved to be the most difficult in getting the packet produced.
Which you all voted for us to not have moving forward next year because of it, because you have holidays in November and December. So, yeah, I think.
I wanted to call it forward. I don't have an objection, but I just want us to be mindful that December can be challenging.
I think both December and January.
And I think January is actually more challenging in reality. Right. And so that, you're right.
And you know, depending on what you all vote, I would come back in June with the dates for 26, looking at the spacing and not on a holiday, you know, for 2026.
But it sounds like
Those people that enjoy holidays, I don't know who they are.
January and preparing the reports sounds more important than, I mean, we can attend virtually too, right? Board members can still vote virtually. We can have a quorum that way if we need it.
Yeah, and then potentially in December, there's nothing that's needed on a public policy day, and we don't need 2 days, and we cannot have a public day.
We really work through. Okay.
Because we have an extra.
Yeah.
Right.
Yeah, you might not need that I mean, that could be it right now is why have a sixth public one if you don't need it? December's just one day.
Hmm.
Last clarity, if we move forward to approve this, next month is going to be canceled.
If you all
Okay.
say it can start now.
Okay,
And-
just clarity.
Mm-hmm.
Thank you.
Mm-hmm. And we would see each other again in June. And we would have time between now and June to get those a full,
We got another question about June,
yeah,
the venue.
yeah, yeah.
And
So,
we are, I want to be mindful of our time. We're
Yeah.
moving into our guest.
we are, and
Would
then
it
we
be,
have,
be better to return to this discussion
yeah,
first
let's,
thing in the afternoon?
let's do that.
We can digest a little bit and
For the
then we
motion.
can decide on the motion.
I like that idea. Okay. Thank you.
Well, while they're getting this up, I want to say thank you very much for having me come here. I think that I came and spoke to all of you back in November and was able to talk to you a little bit about Oregon's nursing workforce and some of the interesting challenges that we're seeing in Oregon right now that's related to nursing workforce. But there's a lot of new faces. There's a lot of people that I don't know. So I want to introduce myself and just tell you a little bit about the Oregon Center for Nursing. My name is Jana Bitten, and I'm the Executive Director of the Oregon Center for Nursing. I've actually been working at the Oregon Center for Nursing for 15 years. So I have seen a lot. I know where some of the bodies are buried, and I am really happy to have this opportunity to come speak to you today about the nursing workforce, but specifically about the Oregon Center for Nursing, so that you kind of understand what we are and what that's all about. So, as an introduction, for those of you who don't know, we are a nursing workforce center, which means we are an independent nonprofit organization with a mission to make sure that we can advance the nursing workforce in Oregon. We want to make sure that all Oregonians have access to a highly qualified, highly educated, well-prepared nurse in whatever setting that they need them for as long as they need them. But in order to do that, you kind of need to think about the nurse and not the patient. Like we want it for patients, but we need to make sure that the nurses are taken care of and that we really understand about what nurses do and where they work. So one of the pillars of what we do really centers around data and research. As I was just explaining back here, when it comes to workforce data, you're going to find it in a lot of different places, like the Oregon Employment Department, the Board of Nursing has a data set, the Health Authority has a data set. There are lots of different places you can get data. And basically, the Oregon Center for Nursing is, right now it's 5 nerds that we put into a room that all we do is look at data. And we do this because we want to be a resource to all of you and to be able to answer questions that you have. So first of all, just to put it into context, we are not the only one. When I first started, there was about 30 nursing workforce centers across the United States. Currently, there's 48. And each of these workforce centers are a little bit different. These workforce centers are, they're a very, very diverse group. It's really based on their size, their funding sources, the issues that they are trying to deal with, and also their organizational structure. You can see there 28% of all of the nursing workforce centers in the United States are nonprofit organizations. 28 are within state agencies, including boards of nursing, and 23% are within universities or colleges. We are a nonprofit organization, and when it was formed, and I'll get to the history about how it was formed and what happened there, but when we were formed, it really was about, they wanted it to be a nonprofit organization so that we could be independent. So here's our history. So we were formed in 2002, really specifically to look at the nursing workforce shortage. So at the time, at the beginning of the 2000s or the aughts, yeah, a long time ago, we were looking at data that was showing that 2010 was going to just have this drop off and this nursing shortage that was going to be catastrophic in the state of Oregon. So they formed OCN, and OCN, our job was to try to get the data, to identify the problem, and then do something about it. So the very first things that OCN did was we did a lot of going into high schools and going into middle schools and handing out plastic stethoscopes. That did happen. We all, many of you don't, even if you knew about OCN, you might not know that that happened. We did posters trying to encourage diversity in the nursing workforce, including posters to encourage gender diversity in the nursing workforce. We did all of this work, and then 2008 happened, and the recession happened, and the nursing shortage did not kind of go as planned. But one of the things that we noticed as we were doing that work from 2002 up until 2008 and into 2010 is we started to notice the things that we were doing, the work that we were doing wasn't necessarily moving the dial. It wasn't reducing the nursing shortage. So we really spent a lot of time looking at the data and coming up with these evidence-based solutions. And I'm going to describe some of those solutions that we are working on right now so you can see what that is. You probably get a report about this all the time, and yes, I made sure I didn't wear that same shirt today. You get a report on this when you talk about what the Oregon Nurse Advancement Fund is. And this basically is the money that is set aside from nurse license fees that's directed to the Oregon Center for Nursing. It has 4 prongs to it. I put the rule down at the bottom there. But basically, it was enacted in 2015. It's $9 of every nurse license fee for every time a registered nurse or an LPN licensed in Oregon, and it's directed to OCN to support our work. The 4 pillars of the things that we work on is specifically to look at advancing the profession of nursing.
Recording in progress.
Conducting research study, and also, importantly, to distribute that information free of charge. So when we do these studies, we don't charge for them. We made sure that this is all available on our website for all nurses that are paying the fees. And then also we convene our nursing organizations. So that's what the Nurse Advancement Fund does. Randy, did you let somebody in? There we go. So I do want to explain how much money we received in 2024 and how that money was spent, because I think that since you are the stewards of these fees that you're collecting from these nurses, I think it's important to know for those particular funds how they are spent. So in 2024, we collected $452,223 from nurse license fees, but that only accounted for about 26% of our income. The rest of our income came from state grants that we are doing for some of our work, and I'm going to get into explaining a little bit about that in a moment. And then other sources of income are contracts that we do for research contracts, or if we have an event and we charge people to attend the event, that's where that money comes from. But really about 1/4 of our income right now is coming from nurse license fees. If for any of you, I guess, policy analysts who are around, and you probably have heard me say this before, you might notice that that's a flip. It used to be that the nurse license fee accounted for about 60 to 75% of our income, and that's flipped as of last year. If you look over at the kind of things that we spend the money on, administration looks really heavy, but that's pretty typical for a nonprofit because that administration is our salaries. And so salaries are all put into one piece of it. But if you look at the other things that we're working on, the community outreach, the workforce research, the connection with the National Forum, and other workforce programs, that is what is funded by the nurse license fee, in addition to the salaries. Okay. So we've been pretty efficient with that money, even if it's just about 1/4 of what we've done. This is an example of the activities that we were able to do in 2024. So we held a conference in April where we brought people together from all over the state to really talk about transition to practice programs and share best practices. What did they do right? What did they do wrong? How can we learn from each other? We also have been putting on something called an Outstanding Nurse Preceptor event. This is an event where we can give some meaningful recognition to those nurses who are working as preceptors just throughout the state of Oregon. As far as research goes, we also conducted a wage study, and what we were able to find in the wage study is that wage growth in Oregon for nurses is slowing, and it's very uneven across settings, which a lot of this you probably know, but we were noticing that the trends are that it's slowing. We are also noticing that the geographic wage differences reflect cost of living and competition. We found that even though nurses who are living in the Portland metro area might make more money on paper, because of the cost of living, they're not actually going to be living there. You would do better if you were a nurse living in a rural part of the state just because the cost of living is so much lower. So even the numbers don't add up, because basically what we're saying, if you want to actually make, like I sometimes will say, if you want to buy more stuff at Costco, don't live in Portland, and even though they make more money. We also know that workforce equity among wage is a huge issue. Men and white registered nurses tend to earn more than their peers, which it's not surprising, but whenever you get data to back that up is a little bit, take a deep breath about that. But yes, we do have some inequities about how pay is structured across the state of Oregon. We also have been using the nurse license fee to really develop the concept of the vacancy crisis. And when I came here last fall, that is what we were talking about. This concept of We have more registered nurses than we have ever had in the history of the agency, in the history of the state, and yet we are still experiencing extremely high openings. And so you have this mismatch where you have so many people that could be taking the jobs, but not a lot of evidence that they're taking the jobs or taking the jobs for a long period of time. And I think that that will, if you want to ask me some questions about clinical placement, this all ties together. I will go back to the study that we've been doing there. But we've been able to develop this concept to really understand, is Oregon in a state of a nursing shortage? Or is it something different? Because if it's something different, and it is, the data is showing that it is, that's a totally different set of solutions that we should be really pursuing. In addition to that, in 2024, we partnered with the Board of Nursing and put together a podcast called The State of Wellness, where we worked with several members, several policy analysts, and Director Prusak herself, to put out 6 episodes of a podcast just really talking about nursing and nurse wellness in the state of Oregon. And then finally, the Friday Huddle, which I think a few of you have come to at some point. So, and if you are all welcome to come to that. It is a call that we hold every Friday morning for 1 hour. It doesn't really have an agenda. We have a few things to talk about, but we try to talk about nursing issues and nursing workforce issues, so we can kind of get an idea about what is it like for nurses in rural parts of the state, or nurse educators, or nurses that are just, or new grads that are just going into practice. The last one we had was really interesting, where we were talking about, if we're going into a recession, how hard is it going to be for a new grad to find a job? Which, you know, that all comes up organically. And you're welcome to come and join and stay for as long as you like. It's kind of it is something that the nurse license fee funds, and I'm really happy that we had that opportunity to do that. I would be remiss to talk about all of those things that we were able to do with the nurse license fee and not let you know about the grant-funded programs. These are programs that are not funded through the nurse license fee. They're funded through projects that we have going on the state. But as the board, I really want to make sure that you know that this work is being done, because it would influence some of the decisions that you make, or at least be able to inform some of the decisions that, or some of the things that you need to be asked to think about. The first one I want to tell you about is Renew. This is the project that was funded through the state legislature, where we are doing where we are going to be doing pilot programs with publicly funded nursing education programs, so OHSU and the community colleges, to really identify what can they do to recruit and retain nurse faculty. We have already done the first phase of this project. We've gone to just about every single one of these schools and conducted interviews, focus groups, and we're now in the process of having each of those schools submit to us a recommendation of what they would like to use the money for. And then we were going to give them a grant to pilot those programs. They could try to and show us what are the best and promising practices that come out of those programs to really improve the recruitment and retention, with an emphasis on retention of nurse faculty in our nursing education programs. The other program is the RN Wellbeing Project, and this is a project that we started about 4 years ago, tying a lot into Director Prusak's message of nurse wellness as public protection. It really is looking at the emotional and mental well-being of nurses in different settings. We were able, through some grants that we were able to receive from Senator Merkley's office, and also from the Oregon Department of Human Services, be able to do some pilot project grants in the same way, where we've just finished up those, to find out what were some things that really worked well, and what were some ways that we can start changing the underlying environment where nurses work, so it can be a better place for them to go and stay, and we don't have so much instability in the nursing workforce, because that does impact patient care. You'll be seeing a lot more about the RN Wellbeing Project in the next few weeks and months, because since those projects have now finished and we've gotten final reports from them, we want to be able to share with you all of the good things that they had, and there's going to be some bad things, and we'll talk about those too, but maybe not by name. And that's it. So I wanted to give you guys as much time as possible to ask any questions that you might have. I might know it off the top of my head. If I don't know it off of the top of my head, I would be happy to write it down and get back to you later. So do you have any questions?
I'm curious to hear about the results of the study of was it a nursing shortage, or was it something else? You alluded that it was something else.
Sure. Yeah, so what we have been able to determine is that in the state of Oregon, we are seeing record levels of turnover, especially in hospital settings. In some cases, and I've used this statistic before, but in some cases, we have been able to see that there's about a 30% turnover of a nurse within the first year of employment. And more than half of that 30% is a new grad. So what that is telling us is that nurses are going into the workplace and they're either not feeling prepared, actually we know this, we've surveyed them, they're not feeling prepared, they're not feeling supported, they feel like the work is not what they expected, and then they leave. They don't leave nursing, they just do something else because there are so many different places for nurses to work now. So what ends up happening is it creates the illusion that we have this massive gap of the number of people who can practice and fill those positions. But we don't. It's really, there's things that need to be done systemically within the organization that if we could actually impact that, then that's going to reduce the turnover, reduce the turn, stabilize the nursing workforce, and get us closer to the state that we'd like to be in.
Do you know where they're going? Have you surveyed them to find out what other avenues they're pursuing?
It's really hard to get that information. The best way that, it's very hard to get that information. We know that a lot of times exit surveys when people are leaving their employment, they're not always accurate. They don't always say the right thing. But what we are, so we don't really have we don't have a data set that's captured that. We just know from talking to them at the huddle and talking to other people and just collecting some anecdotal stories that they're not necessarily leaving nursing. They're just leaving the position that they are in. So.
Oh, okay. I wanted to add, because it was such a great presentation, and there were so many good analogies and specific pieces that stood out for me on that nurse vacancy crisis.
Mm-hmm.
And just like global view, one of the things, and I hope I got these numbers right, Oregon population has been going up around 11%.
Oh, opposite. It's been going up less than 0.5% a year, and nurses are growing at about 11% a year.
Oh, okay. Sorry,
Yeah,
that's
it's
the
okay.
number.
Yeah.
So the amount of RNs we're having come into the state far outpaces our population growth. And then like on the national level, like our nurses per capita kind of numbers, Oregon is a little better than average. I think 18
Mm-hmm.
nationally. And so then switching the line to the story really and focusing on it's the nurse vacancy crisis. There was the analogy of like the leaky bucket, right?
Yep. Mm-hmm.
Rather than having, not enough water. It's just that when people quit a job, what's the gap between jobs, right? People are usually like, I want to take some time off. I want to do these other projects, 3 months. And so that's 3 months where you have a nurse not working.
Yeah.
Which is when a nurse stays in. And so that I think explains one piece of that. It's not just that people are choosing to no longer do nursing, but those gaps in employment.
Did that survey, were you looking at permanent positions versus travelers?
Yes.
Okay, so what did you find there? Were the positions just vacant or were they being filled with traveling nursing?
A lot of times the positions were being filled with vacant positions, and they were being reported they were filled with travelers in some cases, with the idea that they were, the travelers were only going to be working 1, maybe 2 contracts, and then they're going to be moving on.
I would say that I think that that's a massive trend in new grads that I've talked to, is that they are going into nursing to be a traveling nurse. And so they'll do, if they could, they probably would go straight out of nursing school into travel nursing just for the financial incentives. And I really feel like there was a huge uptick in that after COVID.
Yes, there was. Before COVID happened, we did a demand study of all of 4 different groups of employers: acute care, long-term care, public health, home health. Maybe it was public health and home health were separate. Anyway, what we learned is that prior to the pandemic, long-term care did not use travelers. That was not an option. They didn't use them. Now, travelers do go into long-term care a lot. We've also seen that after the pandemic, a lot of our acute care partners have really ramped up their residency and their transition to practice programs. They're taking more new grads, which is great, but now there are less new grads that are going to go into a long-term care setting. So that puts more pressure onto long-term care to reach into getting travelers in order to fill some of those gaps at the same time. But kind of to your earlier question, when we see them leave or when we hear about what they leave, we don't hear them leaving nursing. They're not leaving nursing completely. Some of them are, but most of them, their nursing is such a fragmented, but in kind of a good way. It's just such a diverse field that you can do a lot of things with a nursing license. And if they're not, the society that we're in right now is not really tolerant of an environment that they don't want to be in, and there are options, so why would they stay?
Well, so looking upstream a bit, because you know me, I'm all about the education side.
Right.
Because you said over half of these people that are part of this massive turnover are new grads.
Yep.
When you talk to them, did they say, wow, in nursing school, this would have been really helpful? I mean, did you hear anything about how they could be better prepared? Because you said that they got into the work environment and they were like, this isn't what I thought.
So that statistic is actually coming from a national study because we don't have that data specifically for Oregon. We just have that verified to us from some of the nursing leaders that we've been talking to. So what I don't know specifically, and that's actually a good question because other people have asked me this too. I'm noticing that on the national circuit of all the conferences that they're talking about, I'm seeing that the topic of transition into practice is really getting big again. Because I think very specifically, they're looking at, well, if you have a new grad who's taking their first job and they're bailing out of that first job in their first year, but they're not bailing from nursing, is it that they were ill prepared for nursing or were they ill prepared for that job? And that's kind of what we're starting to suss out a little bit right now. The argument is that they probably were ill prepared for that job because that job has some systemic foundations that are set up to create an environment where a nurse isn't going to thrive. And that not just because it's not just about getting a paycheck. We know this. The state of Oregon, we're consistently in the top 5 of the amount of money we pay registered nurses in our state. And yet, we still have these openings. So if we're paying them a lot of money, that cannot be the only solution. There's things that are happening in the environment, and that is, and there's also things that are happening in society where the people that are taking those jobs are a lot less tolerant of the conditions that are there.
Well, look at the national trends of violence against nurses. I
Yes.
mean, and how well supported they are by their employers.
Yes.
Silent.
Exactly. It's a thing, and that's part of the reason. I've talked to new grads who have gone into the workplace and they're like, this is nothing like my clinical placement, which makes sense because for a lot of programs, when they have their students in their clinical placement, they want to make sure that they are getting the best experience possible, so they are going to shield them from workplace violence at the level that they might might experience, or shield them from some of the, some of the toxicity that might be in an environment, because that's not where you're going to go for your clinical placement. But if you get your first job and you walk into that situation, you're like, this isn't what I expected, and then you go and do something else.
Yeah, I feel like that, and I promise I'm not saying this just to support my thing around final clinical practicum, but I feel like that is one of those times where, because in the cohort model, you have like 8 students and their faculty, and they're kind of all, your faculty's like kind of hovering. I mean, you might be on 3 different units, but the faculty is close by and able to like discuss things with you. But when you're in a one-to-one experience with a nurse, I think students get a more realistic view because that nurse, well, and the thing is too, is that toxicity piece. They go, oh, I want to be in the ICU. And then they go into that setting and they're like, they're understaffed. None of the nurses want to teach me. And I'm not saying this is all ICUs at all, I promise.
No.
But like they go into that setting and they go, oh, maybe I don't want to do that. And I also, a thing that I hear from most students is they want to go into acute care, and really ICU and ED are the best ones. But those are also the ones that we see people cycling out of, because the violence and it's a very high stress environment. And so anyways, I'm just trying to think of like, how could we better prepare them? Because the other piece is then that's what, $100,000, $200,000 to the employer, who's then like, I don't have enough money to pay my nurses more or to do these other things. And I feel like we potentially lose really good people because they get demoralized.
I think you're exactly right. One of the quotes that we took away from one of our well-being projects that we've been doing is a known stressor is so much better than an unknown stressor, right? And so when we think about like what kind of environment are we putting people into, it isn't just what are the skills that they're going to need to know about the human body and about how to, take care of that human body. That is important and that is on the NCLEX. But there are things that are not on the NCLEX that we really do need to make sure that students and just the public actually knows that that's the environment that they're going to be going into. And as long as they know it, it doesn't mean that they're not going to do it. It just gives them a chance to prepare for that kind of a situation.
I think one of the things that schools could do to better prepare students for nursing practice is to be able to, because it's so much focused on caring for your patient. And when you're actually working, you almost have to be semi-removed from caring for your patient because you're going through the highs and lows of the human experience with them. So whenever that day ends and it's a real low day, something terrible happens, I mean, you have to be prepared to take another patient and do it all over again. So you're constantly being kind of drained.
Yeah.
And that is, I think, kind of very hard to adapt to.
And there's been an expectation in the past that if you're a nurse, the expectation is that you adapt to it. And I'm sure that for all of you, you adapt to it. The generation that we have and the society has kind of changed, that they have learned that, no, they don't have to adapt to it. If they don't like it, there are other things they can do. And they're right. They're right. So there's an element of adaptation and there's an element of wisdom that they're going to get, but they don't have to just stick it out. That doesn't exist anymore. And if that doesn't exist anymore, what are we doing what are we doing foundationally for our healthcare system and the way that we deliver healthcare that takes that into consideration so we have a stable nursing workforce?
Do organizations reach out to you, because we do know that a lot of these environments are very toxic.
Yeah.
Are they reaching out to you for assistance in, I'm going to use it, detoxifying or, looking for ways to make the environment one that people would want to stay?
So we are a place that has a lot of good information, and we're still kind of putting together the solutions. However, I know that the American Organization of Nurse Leaders has done a lot of work in trying to help nurse leaders be able to kind of embrace some of these leadership aspects so they can detox their environment. I also know the American Association of Critical Care Nurses has a huge program about healthy work environments that they have been promoting. They actually used OHSU as a pilot study where they had, I think it was 17 different elements of what a healthy workplace looks like. And they started to, and how to implement that. And so then OHSU was able to implement that in a couple of different places. So do they come to us for us to tell them how to fix it? Not really, but they do come to us so we can point them in the right direction of who can give them the best information.
Director Bitten, so it is 1 o'clock, but
yes.
but we don't have anyone in our Zoom room, and the 3 that have signed up aren't here yet. So let's continue. But what do you think about the work that you all are doing about wellness and the grants that were given, and now the research or the data from that, and potentially systems learning from that? Don't you see that as something that potentially Oregon Center of Nursing is engaged in by systems looking at what you're doing, what they're doing because of working with you or getting grants, and then what went well and what people might adopt?
Exactly. And that's why in the next few months, you can expect to see us talk about this a lot more, because those final because those final reports have finally come in and we have a much better sense about what went well and what didn't go well. I mean, spoiler alert, the projects that went well are the ones where they actually asked the nurses what they wanted and gave it to them. I know, crazy, right? Are you kidding me? No, the ones that did not work well are the ones where they just assumed that they knew what the nurses wanted and just implemented something just based on an assumption. Or that. So, yeah, I really hope that in the next few months I can, if you'll invite me back, I would love to come back and kind of share some of the results of what those projects are around well-being. And I'm happy to come back at any time. And you are always, each individual person, you are always welcome to connect with me and ask me just even the most random questions, because I can't say that I know the answer, but I know how to find the answer. So.
Well, I think one of the things that I think will be helpful is around the preliminary research on faculty as well as clinical placement. You were here this morning and know it's a topic of discussion.
Absolutely.
But where is our role? How do we wade in and out of that? But also just information in general, so we can work on that too.
Yeah, I've actually been talking to Policy Analyst Black. I've been talking to about what kind of a study could the Oregon Center for Nursing do in conjunction with the Board of Nursing to understand the clinical placement environment better.
The legislature might direct us to do that together in the future.
The legislature might direct us to do that together in the future.
There is a bill moving through the legislature.
Yeah, there is a bill going through the legislature that we're going to see, and I kind of do hope that that passes, because I would be really excited to do that work. And even if it didn't pass, I would probably make us do the work anyway. So
yeah, and I think that's
really important.
And I think that's what I was referring to earlier. Like, what role is it that we're in to regulate, but what role is it that we can collaborate outside of regulating? Yeah.
I think one of the important things just to note about OCN is that because we're separate from the Board of Nursing, we can give you recommendations on, where, if you want to regulate something, where's the guidelines that you can choose to, because you can regulate things as much as you want or as little as you want. But we can also kind of give you some ideas about, we're kind of moving into a new world of nursing and healthcare delivery, and how do you, as board members, how do you want to regulate that for the state of Oregon, and how do you want to influence that? And we can inform that for you.
I definitely would like to see some information just on the clinical placement issue, just to understand the scope, because it keeps coming up.
Yep. Yeah.
And the impact on nurses and students and in Oregon.
Yeah, it does keep coming up. It's been a persistent problem for the entire time that I have worked here. Yeah, it's just been a persistent problem. And my experience is, if you're going to have persistent problems, then that kind of means that is it a feature or a bug? If it's always going to be there, where is it really a problem, or is it just the way our system is built? If we don't like it, then how can we rebuild the system in a way that's not going to always leave us in a place where we have this scarcity of clinical placements, or this confusion about where clinical placements are available and where they are not?
And Board President, I know that we do have people now. Mm-hmm.
Yeah, I was at this point, because we have the public forum, and we really appreciate your coming here.
Thank you. Again, thank you for having me, and thank you, and I am more than willing to come back if you need me to, or if you'd like to reach out to me, please feel free to do so.
Did you say you were open to hanging for a little bit? I don't know how, well.
Yeah, I'm open.
This will be till 1:30, and then you have a
okay.
30-minute presentation, 1:30 to 2.
Oh, never
So,
mind.
and then we're
Next
done,
time,
except for you bringing me back.
Probably better next time then.
Okay, that's fine. I can hang if you need me to, or
hang out and just see how it goes.
I'm going to hang out and see how it goes. If it doesn't work out, then I'll come back. Thank you again. I really appreciate the opportunity.
So we are now going to move into the public forum phase. I have a name of one person that might be on the Zoom. Tesfaye Wayesa. Are they still there?
They are, and there is a second one that just joined us.
So I'd like, Tesfaye Wayesa, I can read at least the script to let you know about this engagement formally, and then we'll give you the 5 minutes to speak. So welcome and thank you for joining our public meeting today to share public comment. It is April 17th, 2025. The open forum is from 1:05 to 1:30 p.m. Each person will be allotted 5 minutes. Open forum is a time for members of the public to make general observations and present items of general interest. Open forum is not an opportunity to make requests to the board or to discuss matters currently under investigation or review by the board. The board will not deliberate on any issues or requests during the open forum. The board president has the authority to stop an individual's comments if the board president determines that the comments go beyond this directive, or as necessary for efficient and orderly conduct of this meeting. So I'll turn now to Tesfaye Wayesa. Would you like to speak now?
Recommended to turn on camera, or at least, obviously, and then if not, unmute yourself. I'm just going to support you as best I can, given the new.
Did you hear that, Wayesa? Or you could turn on your camera and turn on your microphone, and we will give you 5 minutes to speak in the. Still muted. Oh, maybe they're having technical problems.
Okay. Yeah, sorry. So
We
my
hear you
camera
now.
is on.
Hey. Yeah, yes, we hear you now. Please start from the beginning. Introduce yourself and then.
Okay. Okay. Thank you so much for inviting me. My name is Tesfaye Wayesa. So I'm currently doing my CNA course. So I just want to share some of the challenges that I observed in Oregon. So if I want to share just if there is a possibility to adjust or resolve it by the board. So one the challenge is related to availability of healthcare resources concerning immigrant. So comparing with other states, because now some of the courses I am taking from Minnesota, because there are so there are opportunities there, several opportunities. The education, the costs are very, small, minimal, so that as an immigrant, I can afford it. So there are some scholarships where some of the colleges offer and the schools offer. So
Mr. Wayesa, I think we lost you.
Oregon, so that. Oh, sorry, am I back?
Yes, we can hear you again now.
Yes. So yeah. So in general, like in Oregon, I observe that education are expensive. So for us as an immigrant, we can't afford. So I really request if there are some scholarship and also some opportunities, scholarship for CNA as well as medication. Say that as an immigrant, we have dream, we are professional. Really, we want to integrate ourselves to the workforce easily. So if there are easy paths to this opportunity, I would like to appreciate that. So this is also to note that these scholarships as well as easy paths to integrate immigrant to the workforce is available in other states. If you could really check from other states and resolve this issue and make easy to immigrant, that would be good. That is what I observed really. Thank you so much.
Thank you for that testimony. We had, I believe, someone else also on the Zoom call. Okay, then I will. Did, Aga Ayana? Please, could you have a seat at the table? There's a microphone. Oh, there's a microphone right there. Before you speak, you have to press the button and it will turn green. You press the button right there and it will turn green. Remember, you have 5 minutes for public testimony where you can speak, and we're not allowed as the board to respond to that due to the state laws.
Okay, thank you. Thank you for giving us this opportunity to express our concern related to.
Sorry, I won't start the timer yet. Could you say your name? As an
Ayana?
introduction, first off. Thanks.
Okay. I continue after introduction, or?
Why don't we start? Introduce yourself,
Okay.
and then please jump into
Yes.
what you want to say.
My name is Aga Ayana, and I recently came from Minnesota and planning to move to Oregon in the future. So I'm just working. I'm president of Ethiopian American Association, and also working in the healthcare field as a RN since 2022. So today I just some of our community I'm representing, and also speaking for myself also as because I think many concerns we have as people I have connection in Oregon, they have the process, they have difficulties in going to nursing and the healthcare field to get their education. Because in Oregon, they say which I also witnessed through my researches. So one of the things we have is they don't have, there is no enough resources, people to get into the nursing assistant training, because nursing assistant training is, as you know, it is a door to put the step to get into the healthcare field, to become training medication aid, RN, phlebotomy, LPN, things like that. But people they don't have any ways to get into the system because there is no lot of resources, like comparing to my state and the other states. Because recently, like in Minnesota, we always receive the requests we asking, because recently nursing assistants test is changed to our language. Students have the opportunity to go back and forth to answer the question by their own language, by our country. Recently, Hispanic, Somali, and the Hmong language added. Ethiopian language will be added very soon. This is how far we get support from our state and the other states. But in Oregon, it's even we want to be a bridge for the between community and between this organization, between you, so that we can reach out to the people you want us to reach. We want to be a bridge, but we have a difficulty even to start the training business, which I myself witnessed. It take me almost going to be 1 year to get the resource I have to get to start this business, so I can reach out to the people. And the one is that the difficulty of starting the business for the training, so people can go and they move into in the healthcare fields. The second one is people are in our community that the people are tired of sitting 20 hours, 16 hours home care work, because they need their health. We feel like this is the opportunity we have in Oregon is only the job that the American don't want to work, because nobody wants us to sit 16 hours of work, that is only the opportunity they have without nursing assistant certificate. If they want us to help people elderly and the disability, they want us to do that, because that is how we grow up as a culture. That is, they want us to pursue their dreams, a purpose job. But since there is opportunity going to school as a nursing assistant, because they have to go to school for 1 month, 2 months, all day sometimes, and that is impossible for people who already struggling financially to serve their community, and especially for women who have full responsibility for their children. Though there is no chances, like such like opportunity in Oregon to learn an online nursing assistant certificate, or you don't give us opportunity to open our business so we can provide child care support in our training center that we can reach out to our community and we can get volunteer people in our community to watch the children until the mother gets the education she deserves. Most of them are RN degree in back home. They know how to do this job. They have been working in a hospital, very fast track place. And here when they come to in Oregon, since there is no chances, they ended up working sitting only with one patient. People wanted to work with 20, 15 patients in long-term care in the hospital. That is what they dreamed of. So I'm just asking to give us American opportunity. Everybody wants to go. They are not here only to work and they go home and they pay bills. They want us to also taste the opportunity they have in this country by going to nursing class. Yeah. Yeah, I know.
At 5 minutes, the board appreciates you coming in person to give this testimony very clearly.
It's
Thank you.
unfortunate I have only 5 minutes, but in the future, I hope I get more opportunity.
And there is, as you know, there is ongoing communications that you can have with
And he has,
the
we've
staff,
met.
So, yeah. I'd like to turn to the next person on my list to see if they're here, Gamechis Fite. Or if not, then I'll move on. Eba Heyi. Please introduce yourself first off, and then go into your testimony and all.
Okay, thank you for having opportunity to meeting you. Wishing for long time. One day I'm meeting the board. I'm currently working as CNA. My name is Ebaye. I'm moving from Minnesota 2 years ago. I get in training with him in Minnesota, but is to transferring a lot of struggle to transfer here. The bureaucracy is board of nursing is very tough. I'm passing that one anyhow. Thank you. Some of them I calling every day, like answering the board of nursing customer service. I am say to thank you. So helping me now. Currently I working to health facility, post-acute care. But what I see is I try to go in nursing, CNA, nurse assistance. Again, if my license is not like transferable, I try to approach. I see only one as Oyer University, something. They are very expensive. They charge like $3,000 for who have family, who have kids. $3,000 is very expensive. I wanted to college to get in certified nurse assistant again, because the other opportunity I have multi skill. I have it. I have HVAC degree in Minnesota. I working on that. Previous, I try to transfer here a board of license of building coding. Gonna be a lot of bureaucracy, and I don't want to face that issue here. Also, the chance I have when I come to here, only healthcare system. That is only available, the open job opportunity. When you come to the training, there is no resource. I go college, they say go class, taking that 3 months almost. They ask you to go in college to get in training. 3 months is not only training. Before of that, you take like English, maths, a lot of like class you have to take before of that. Getting that the training. So I told the first guys, I'm calling him, please, can you help our society here? A lot of immigrants, refugee people is here. They don't access to door to work. Just they sitting all, especially the women have kids. They don't have any training. Without training, nobody's not hire you. The law is restrict. So I offer him, please, can you come to here, Oregon? Our community is service giving training. If you open a school, even though we don't need the money, after they hire, they pay you monthly, like credit, giving credit. You're gonna open door for all loving work instead of sitting on government welfare. That I call him, he come to here to offer him. But when he come to here, the same he get is bureaucracy. But is what I'm thinking, after I get like nursing home, they are suffering. facility because they are shortage of CNA. Even though I work 60 hours every day call me. I make money, but other people, they don't get opportunity. They are short. We're working like sometimes 7 people, the board is set up. The low is 7 people until 9 people, even in the morning shift. How the other people? They have like many people. Sometimes they enforce you to taking care of 10 people. For one CNA, they have to cover the facility. Also, they have going from agency. The agency charge more money. Some facility like owners come to, what I'm gonna do is I'm gonna go shut the business. Like that kind of, we don't know how do you get it. They always say shortage. They complain shortage, even though we can't work it. Even I get money, okay? But I'm not like seen individually, but how about other friends who's stacking like group home, foster home, 60 hours they staying there. How about the young, the mom, how to taking care of? If the door is open, maybe I'm thinking the people is, studying government welfare, if get access to resource or training, short time, they're gonna get the job opportunity there. A lot of vacancy. Also, they pay tax. They help government burden of giving welfare for the kids. Also stresses, when I here is when I make money, the government get money, cities getting tax, county getting tax. I work Portland, they take from my check. That's my check is half government, That's when I'm telling you, if you have other resource, only 2-3 people's getting training, why not give access to the people's training more? The people is bringing the market, our elderly people's, disabled people's getting enough service. That is my opinion. Thank you very much. I'm taking a long time.
Thank you also for coming out in person.
Okay.
That testimony.
And just to clarify, Gamechi's fight, we had signed up to Aga. Do you know if they're with you or no? I said the name wrong, I'm sorry. Okay, and then, that's the one.
Okay, my name is Atle Jamana. Thanks to just get this opportunity to meet with you. I have been living here in Oregon about 2 years. Here in Oregon, what I wanted to say is there is a lot of demands who want to attend the classes. Say, for example, here, me, just I work as a caregiver in Cape Town. When my provider just hired the people, there is no qualification people who he wanted to just hire. The great problem is demand of education. No free education. If you wanted to just attend, say, for example, like CNA classes, you just pay a lot of money. Because we as immigrants, I am, say, for example, 2 years ago here, I am not just live here long time. So even the language may be barriers, you see. There is, to just attend all these classes, there is no option to just train our language even too. So what I want to say is, if you have an ability or a chance, give chance for the people who want to have no reach out of just education. That is what I wanted to tell you, please. Thank you so much.
Thank you. Could you do us a favor? I don't know if we caught your name. Maybe you could write it down. Okay, and then we have someone else on the Zoom, the virtual call, to just Seifu. Or is there someone online that would like, maybe because I said your name wrong, you think I'm not talking about you? Is there? Great, thank you. Is there anyone online that would like to speak in the public forum? If you do, please unmute turn on your camera. But if not, no, do we see anyone else online? No? Okay. We do have a little bit of extra time, which we can normally cede to whomever's present. So if anyone else, if you would like to speak further, or anyone else that is here would like to speak in the public forum. You seemed, Mr. Ayana, you seemed like you had more to say. Oh. Unfortunately, we're not allowed to ask questions because of the state law. This board can't ask the questions and we can't discuss this. We definitely hear and have taken notes, and as talked about, the staff will, you're able to reach out and continue discussions with the staff as you have. Yes, yeah, 5 minutes per person.
You can give them the full 5 minutes, and then after that, we can close out. Yeah.
Maqaan koo Daraartuu Katamaan jedhama.
My name is Daraartuu Katama.
Har'a wanti dhufnee fi rakkoo haala barnootaatii fi haala hojiitiin wal qabateen.
Today we are here related to the education and the work-related issue.
Mana barumsaatti barachuudhaaf qarshii guddaa nu gaafata. Haala rakkoo keessatti kaffallee qofa barachaa waan jirruuf iskoolaarshiippiin akka nu laatamee tuni barachuu barbaanna.
As I heard, like other states, we don't have scholarship here. We have to pay from our pockets. The government is not have that opportunity for us because we don't have the money to pay.
Kan hojiidhaan wal qabate immoo hojii hundumaa hundi keenya wal qixa argannee osoo hojjennee honkeerrirras ta'e haala gaariidhaan osoo wal qixa argannee.
We wish an opportunity given for us who wants to work nursing home and the home care instead of only opening one opportunity bigger than the other, which means we don't have opportunity to go training and work in nursing home or a hospital. I wish you can give attention to these issues so that we can have the same opportunity like others.
Yeroo COVID san kan jalqabe hanga ammaatitti iyyuu hojiin gahaan hojjetamaa jira.
Yeah, during COVID, thousands of people work without license or language requirements. So why now it is difficult since people who work during that time, they did their job.
Rakkoon amma jiru maalidha kan isaa wal qabu maalidha?
Yeah, well, if there is nothing happen, people without license and the language barrier, since they've successfully used during the emergency, why the opportunities there not for us? That's why we want the opportunity to give them back to us and to give them for the people who who are close to us to open the opportunity for us. I started nursing school when I'm back home, and the education is free until universities graduating. But in America, I thought it is also I'm gonna have opportunity to, but it is not. Yeah, that's it. Yeah. Huh? Yeah. Thank you for giving us this opportunity, she said. Yeah, okay.
So that is the end of our public forum. We have a presentation next. I don't know if Casey Cleary, is she presenting virtually? You know, she's ready. They're ready to go? Okay. Sounds like we might have a couple of minutes. Yeah, why don't we come like 1:35? That's not much time. 3 minutes.
We're so glad to be here. It's always so nice to have an opportunity to share a little bit about what PBI does and how our remedial courses work, and how we can help you choose the most correct and impactful course so that your nurses are on the right track with whatever topic it may be that they need. So many of you may know of Catherine Caldecott. She is our medical director, so you may have seen her before, but we're really glad to be here today to share a little bit about it. It's I know Amanda will agree. We're a small team, but we take so much pride in our courses, and we truly feel like we are making a gigantic difference in people's lives and patient safety. So any opportunity to share about what we do is really meaningful for us. So thank you so much for having us. So at PBI, I'm our project manager. I work pretty closely with anyone who refers to us. So any organizations, whether that be a nursing board, a medical board, a hospital system, medical schools. And so I work with them to make sure that they are, if they need any help choosing a course, if they need status updates, things like that. But when I first started with PBI quite a few years ago, I worked directly with our course participants. And so I still work with them a bit now, but when I first started, it was all courses, reviewing assignments and answering any questions they have. So it's been nice to get to work for PBI from both sides with the referring organizations and the participants themselves. And I'll let Amanda just quickly introduce herself as well.
Thank you, Casey. It's really wonderful to meet all of you. Very similar to Casey, I started with PBI about 6 years ago in the same role that Casey did. So we both have a lot of experience working with participants, hands-on, guiding them through the courses and the requirements. My current role as Director of Communications, I work with any publications that we're doing, new course development, and working with boards and different stakeholders to make sure that we're meeting their needs. So excited to be here, talk to you guys, and just share more about what we do.
Thanks, Amanda. So we have the slide set here, but at any point in time, if anyone has any questions, I am more than happy to just stop and take those when you have them, or you can save them for the end. Whatever you guys would rather. It's kind of nice to have a nice conversation instead of just the slide set up. So please stop me if you have any questions at all. So our presentation today will be a little bit of a peek inside our classroom, but also how to choose the correct course to ensure the most impactful education. So the topics that we have and what situations are most appropriate for different situations. So I'm sure many of you already know a bit about PBI, but just some general background information. PBI has provided remedial education to healthcare professionals for over 20 years now. We work with over 1,000 organizations like state nursing boards, medical boards, hospital organizations, and licensees come to a PBI course for any number of reasons where they may have went astray and got themselves into a little bit of trouble with their professional license. So our course topics overview is, first up is professional boundaries. That is what PBI stands for, so that is what we're most known for. But we've, over the years, have added on a number of other courses. So we also offer an ethics and professionalism courses. We have a 1- and 2-day option there. We have a civility and communication course, medical record keeping, proper prescribing, and one of our newer courses that we're really excited about is the risk management essentials course, which I'll talk more about each one individually, but we're excited about that one. So before we talk a bit about what topics, what situations are appropriate for which topics, I just wanted to give you a little bit of background information about the course nuts and bolts. So what actually happens in this live virtual classroom. So it's delivered on the Zoom platform, pretty similar to how we're all here now, so we can all see each other on the screen. And the course is, it does have slides, but the slides are merely prompts for discussion throughout the course. So the course is much more interactive than just slides being shown. There are a number of exercises, there's videos, there's group activities. So those slides are just prompting discussion and participation and collaboration with the group. Participants are also required to do pre-course assignments. So you'll see here faculty advanced preparation. The faculty will review all of these pre-course assignments well before the course starts. They review every single referral document. So that would be like a board order or an investigation report or some sort of letter of concern. So even though the course is a set curriculum, they will really customize the course to what specific issues are being had by each individual person coming to the course.
I want to jump in really quick, Casey, and just add, similar to how we're all on Zoom right now, when we do the course, participants are required to be visible. We want everyone to feel like they're face-to-face. We used to do these courses in person quite some time ago before everything went virtual. So we do require, if someone was in a room similar to how you guys are right now, and we can only see them really small, we would have our course proctors reach out and say, hey, first of all, you need to be in a private space alone. But second of all, we need to be able to see your face. We want to see you interacting with the other participants. We need to know you're paying attention. So that's the one big difference between kind of this type of Zoom meeting and our courses is we really hold them accountable for participating, not just so we can say that they did the course, but so that they get the most out of it. So that's kind of a little bit of a difference.
Thank you.
Yeah.
So a little bit more about the pre-course requirements. We do have every participant that is registered for a live course do a Zoom, we call it a tech checkpoint meeting. And so that meeting is just very brief with a member of our staff. One, to test out their Zoom capabilities. Are they having any IT issues? We work all of those kinks out ahead of time. But another really effective result of those checkpoint meetings is a lot of times, and I'm sure you all have heard this at some point, is that the licensees are maybe not so happy to come to our course. They are feeling, it might be a really difficult time in their life. They've gotten into trouble. And so a lot of them come to the course with, what is going to happen? Why am I here? And so it gives them a touch point with a real person, a member of our staff, that can answer any questions they have that they're nervous about attending. We want them to be comfortable when they come to the course because that is a huge part of the effectiveness of the course is them being able to open up. So this is just one way we get them to feel a little bit more comfortable coming to the course. We do collect identity verification in that meeting. So since we're in the virtual world, we want to make sure we have the right people there. And then we talked a little bit about the pre-course assignments already, but the pre-course assignments is really where the journey to their transformation throughout this course starts. It's not just the live course. In those pre-course assignments, we ask them to do a number of things. Might be readings, it is self-assessments, and most importantly, we have them write a narrative of why they are coming to the course. So it's really, really helpful for faculty ahead of time to see any document from the board, and then we also see their version of events and are there any gaps or is there anything that they're not really understanding? Usually faculty can tell that ahead of time by that story. The faculty encourage the participants in the course to be as open as possible, as we mentioned earlier. So not only do they have to submit that story ahead of time in writing, they're also required to, in front of the group, tell their story verbally. And so they'll read those pre-course assignments first, and then what faculty will do to be strategic about getting people to open up is they can usually tell if someone is a little bit more resistant just by their story. Maybe they're not fully accepting of what's happened. Maybe they don't see the bigger picture. So the faculty will look at the stories, and whoever in the course seems the most open and maybe is further along in their journey, they'll have them go first when they tell their story. So that way, for those that are a little bit more resistant and a little bit more closed off, they see the group open up first. So they do that in order to help people feel a little bit more comfortable. I heard this in one of the presentations earlier when I was listening on YouTube, but I heard someone say a known stressor is better than an unknown stressor. And so I really like that. That stuck with me with our courses, because a lot of times as they're telling their stories in the course, they don't realize things that have been impacting them and impacting their behavior. So it's really eye-opening for them, especially hearing other stories of, oh, wow, I didn't even realize that this was contributing to my behavior. So I really like that quote.
So just a little bit more about the virtual live classroom. As Amanda said, it's face-to-face, real-time instruction. We do limit our class sizes to 15 participants or less, and we feel that that intimate environment is really, really helpful, and any more than that, it kind of diminishes the quality. So we keep it a small, intimate group. We require that they are dressed professionally and their setting is professional. As Amanda mentioned, that they do need to be in a private space, which is really key to participants feeling comfortable opening up and sharing, really intimate details of their lives and their situations. So if they have a virtual background up, I know we've all seen those, but if they have this lovely travel Oregon background on like the one here, we would just kindly ask them to remove it. That makes everyone feel a little bit more comfortable knowing that there's no one behind them. Amanda mentioned this already too, but we do have course proctors that monitor attendance and participation. Their webcam must be turned on, and we do treat it the same way as we try to treat it as closely as possible to the brick and mortar classroom. And we've actually had really, really good feedback from participants about the virtual classroom. One, that you can see everyone, you can make eye contact with everyone instead of in a classroom where you kind of have to turn and look around. And people are just more comfortable in their own space. A lot of times we'll see like a dog's tail wagging in the background, or someone will have their cat on their lap. But just being in their own space has really been effective in having people be a lot more open about their situation, which is the process orientation of our courses is, why did you get to this position? Not just here's what happened, but what led you there so you can never do it again. So now I'll talk a little bit, actually, before I get into the course topics, does anyone have any questions about just the general course format? Figure maybe that's a good time to just to make sure no one had any questions there.
I have a question. Who's teaching or leading your courses?
That's a great question. So it's always taught by one faculty, and so it's the same faculty throughout the either 1, 2, or 3 days of the course. And all of our faculty are either MDs or JDs, and so they have a lot of experience in, a lot of them have worked for regulators in the past, so or some are attorneys that have worked for a medical board, so lots of experience from what a board is looking for, since many of them have themselves worked for a healthcare board. That's a great question, though. You want to add to that, Amanda? Go ahead.
Yeah, if you're interested in knowing, you can always visit our website, and we have all of their lovely photos and bios on the website if you want to go do some research.
Yeah,
I
and
have on your website. Where is that located?
That is a great
I saw your bio.
Yeah, it's under the About PBI section, I think.
Yeah, there should be a section for faculty.
Yeah. And I know Amanda feels the same way because we talk about it all the time, but one of the greatest fulfilling pieces of working for PBI is being constantly exposed to these wonderful people who are teaching the courses. They are, of course, educated, but a lot of them do this because they truly care about patient safety and they truly care about getting licensees back on track. So it's really, really, it's a great group of people. We do a pretty a good vetting process, and we don't have anyone who's currently working for a board just because we don't want any conflict of interest or for licensees to feel uncomfortable that someone might know that is still actively working on a board.
I want to say just real quick feedback. I love that you ask the participants to tell their story and hone in on their story, because it's the more practice, I think, the better. So kudos for that.
Yeah, thank you. Yeah, it's so Amanda and I both serve as course proctors. We kind of just rotate through our administrative staff for every course weekend, and it's really, really just it's mind blowing. I don't know what other word to use. Transformative, and I have a great quote from a licensee towards the end of the slides, but it's really, so we will work with them in the one-on-one Zoom meeting, and it's so interesting to see the walls kind of chip down. A lot of them come to that Zoom meeting and they're not, very happy to be there. And then I remember the ones that are the most resistant, and I always like to just peek at their course evaluations at the end and see, what they say by the end of the process, and it's really amazing to see the progress that they make in the courses. Okay, I'll go on to our specific course topics and the reasons for referral for those specific topics. So it will help give your team a good idea of which course is most appropriate for certain situations. So first here is the Professional Boundaries course. It is one of our more intensive courses, being that it's 3 days long. And the Boundaries course addresses issues that are relationship-based, involving overstepping professional lines or roles, and that would mean with another person. So any sort of relationship-based issue, which I'll get into the difference between ethics and boundaries because they're very interrelated. But a good way to keep the boundaries course in your mind is that it would be relationship-based, so involving another person in a relationship. So some common reasons for referral for this would be, for the Professional Boundaries course, would be any sort of addictions, dual relationships, so any sort of, dating relationships, or it could be, hiring that person to be your handyman, or, they tell you they offer these services. So any sort of dual relationship. We see this a lot in this day is inappropriate use of social media, text, or email, practicing outside of scope. Treating our prescribing friends, family, and colleagues, that's one we see pretty often. Any sort of sexual misconduct or supervisory issues. So you'll see this picture here this is actually Jacksonville Beach, where our company is based in Jacksonville. And this is actually one of the exercises we have in the course, is this boundary sign that's a little unclear. It's a little faded. And so one of the lessons in the course is that boundaries, can be a little bit blurry. So how to really make sure you're sticking to those. And then we have the Ethics and Professionalism course. We do have a 1-day option for an ethics course and a 2-day option for the ethics course. And so both of these address issues based in violations of law, codes of conduct, or other guidelines or policies. And so the 1-day course would be more suitable for perhaps a first-time offense or something more minor, whereas the 2-day course would be something a little bit more serious. And some common reasons for referral to an ethics course is really anything bending or breaking laws or rules or guidelines. Included under that would be driving under the influence, any sort of financial improprieties. We see a lot of HIPAA violations in this course, or confidentiality violations, any sort of misrepresentation, or something as simple as noncompliance with deadlines or mandates, or practicing with an expired license. And so just as a reminder for Ethics First Boundaries courses, not all remedial course providers separate these into 2 different categories. They may combine them. And ethics and boundaries, they are interrelated, certainly. And good professional boundaries facilitate ethical practice. But we really separate them. And is this a relationship-based issue, or is this more of guidelines, rules, and regulations? The boundaries and relationships, it takes a little bit more time to really dive into that. And so the extra day helps to really get to the root of those issues. So we also have a civility and communication course. This is another longer one. It's 3 days, and it addresses disruptive behaviors and communication problems in the workplace. And that could be with staff, it could be with administration, it could be with patients. We do see this course fill all the time, and it's a tough time to be in healthcare. COVID happened, and then there's new mandates and shortages. So a lot of what we see in this course is really directly related to burnout or exhaustion, or someone hasn't slept, and it causes issues in their personal life. So this course has really, really amazing practical tips in it. And so I'm sure, I know Amanda and I have, but I'm sure most of you there have had some challenging interactions with licensees or people in general. And so this course is really excellent for giving practical solutions to get yourself get the licensee out of what we call hot state, which is when it's just the emotional and the emotions come flying and, anger and whatnot. So this course is great for helping them get practical tips for staying in the more logical state, what we call cold state.
Can I add to that, Casey?
Yeah, of course.
Really commonly when we're talking to people about this course, we'll call it a distressed clinician course, because most often when we see those type of behaviors, they're rooted in something more like the burnout that Casey's talking about. So that's a key word that we really use with this course. If you're seeing a distressed clinician who's really struggling, a lot of times this will help them kind of put things in balance, and it changes their lives. Like all the courses change their lives, but this one really permeates every level.
Thank you. We have a medical record keeping course, which is pretty straightforward, addresses deficiencies in medical record keeping. And just in case it ever comes up, if you need a little bit more, we offer a record review program. We just started offering that. So that is definitely an option where one of our faculty will review records at 3 and 6 months down the line. Proper prescribing, that is also a 2-day course, and also straightforward, addresses deficiencies in prescribing practices, especially controlled substances, pain management, and addiction. And then I mentioned the risk management course earlier. This is a 1-day course, and we love this course. It's wonderful because it is a broad-based overview of the potential risks that nurses or any healthcare professionals face. So this course is basically a condensed version. It takes modules from all of our course topics, so the longer intensive ones, and it condenses it into a 1-day course. So this is a really, really good option if, let's say you're in the investigative phase of a complaint and you'd want them to have some sort of education right off the bat, no delaying. This is a great one that kind of encompasses, the broad range of risks. And we've seen other regulators use this course for, let's say they've investigated a complaint and there really isn't quite enough evidence to enforce any sort of discipline or anything formal. The evidence just isn't there, but the investigator knows that, wow, I hate to just have them do nothing. So we've seen other regulators say, strongly recommend, like it's not written anywhere, but just, hey, we did the investigation. We really think a general risk management course would help you going forward and your patients. And I know we're right on the top of the hour right now, so I just want to make sure I'm not going over time. Did we have 30 minutes or was it longer? Well,
Another 5 minutes, I think.
Okay,
we started 5
perfect.
minutes late.
Yeah.
So,
Yeah, no worries.
We might want to see if any of the board members have questions.
I have a question.
We could pose. Can we? Yeah.
I was just on your website looking at your professional boundaries course, and you have enhanced and extended options. What does that mean?
Yeah, so actually, I'm going to just share this last slide here because it has some good information on the extended. So the extended is, so it's an abbreviation for maintaining accountability with support. So we slang call it MAS, and it can be added onto any live course. They are faculty-led group teleconference seminars. They're 1 hour weekly for a total of 12 total seminars. So this is meant to be longitudinal follow-up where they are it's cohort-based, so they're with the same group and the same faculty each week. And this is their opportunity to take what they learned in the course and enforce it in real time. So how did their week go? What challenges did they have? Are they following their personalized protection plan, which is something they create in the course as their roadmap for going forward? So this can be added onto any live PBI course, and it's really excellent for anyone, but it's especially great for any more, maybe just the live course doesn't feel like enough. This is extra accountability.
I have a question. Well, actually, I have 2 questions. So the first question is, on the 2-day or 3-day course, are they all consecutive in a row? If a person can't attend those, is there a makeup? And then the second question is, med errors seem to be very common. Where would that, because I see the prescriber, where do you have a course on medication errors, or where would that fall into?
Yes, great question. So the first question was, are they consecutive? So for the live courses, we don't allow them to do any partial credit because we feel it's really important for them to stay with the same group and get all of that education in the 1 or 2 or 3 days. So it would, if it were a 3-day course, they would have to take it that consecutive Friday, Saturday, Sunday. And then the second part to that question was, oh, for MAS, for the longitudinal, that one is okay if they were to miss 1 week here or there, say they had a vacation or they were sick. It has to be 12 total sessions. We encourage them to attend every week, but you know, we understand people have busy lives, so if they have to miss a week here and there. And then I think the other question was on medical errors. I don't know, Amanda, what are your thoughts? Any thoughts on that?
I would love to check with Catherine, Dr.
Yeah.
Talcott about that, but my initial response for that would be, it kind of depends on the root of the cause. So was it an error caused by a lapse in judgment, something ethical? Are they too busy? Are they burnt out? So kind of getting a little to the root. If you guys have any more information about that, it helps determine what area they need to learn to remedy their actions in. But we can always, we'll check with Dr. Caldecott and make sure we get any answers from her on that too.
Yeah. Any other questions?
I just wanted to make a comment. I wanted to thank you for your presentation. I thought it was very informative, and I feel like this is an excellent resource to have.
Good. You're welcome. We're so happy to be here. Thank you for having us. Before we go, I'm just going to share this slide just so you have our contact information. We are here for you if you need the status of someone's registration, if you want to know how far along they are in their MAS participation. And also, if you need any guidance on the most appropriate course, like let's say you have an investigation or a complaint and you're like, I'm not sure what course is most appropriate, we are happy to help. Call us or email us anytime and we can point you in the right direction.
Yeah, thanks. And just for the board members to know, I had welcomed the medical director to present to our investigative staff along with the physical therapy board and the medical board. And I thought it would be just a nice follow-up for the board. So thank you so much for joining. And I know how to get in touch with you, and they all know how to get in touch with me. And so I'm sure we'll be in touch in some way.
Great. And I can share these slides too with you.
That
way,
would be great.
Yeah, if anyone wants to refer back to anything, then that way you have it there if you need it in the future. Okay. Well, thanks again so much. I hope everyone has a great afternoon and a good spring.
Thank you all.
Rachel, Director Prusak. I just was wondering, so when we're doing this, like the aren't I? I'm green. Okay. Is that what you were saying? Yeah. Okay, yeah. She's watching, he's watching me. So I'm just wondering, because this seems great, and I really appreciate too how they said we can be a resource. So would that be something that like the board could say, and we're going to, leave it up to the investigator to contact them and identify the best, or would it be better if we identify the best?
I mean, so currently the investigators are really great at knowing the courses that are offered and are really great at doing everything prior to coming. But I just wanted you to have some ownership over also understanding and the ability to really, see it in front of you more. But I think, again, you can trust that they do, but also if there's a space that that's not always done before. There's a space that now you just have this more information. I don't know if there's anything else you want to say to that.
I would agree. I think it would be completely appropriate for the board to ask the investigator to connect and identify what the appropriate educational resource would be.
Thank you, because I was just thinking about, like, sometimes I'm like, well, I don't know exactly what course. So it's nice to be able to say, hey, investigators, this is your area. Okay.
Yeah, they monitor a lot of that stuff, which is why it comes to you that way. But just wanted you to have that opportunity.
Dr. Prusak, now I remember that former President Green had a list of other courses that weren't as expensive as the PBI courses.
Yeah, that is the internal document that all of our investigators have access to. Aaron just had a printed one.
Okay.
But it is the one that, yeah, that they use to guide everything.
And is that information that might be available to us?
Yeah,
Or-
I can figure out how to make sure I put it into a document and share it the way it was before.
Thank you.
I just wanted to point out to the board, just looking at their website, it looks like they also offer post-course follow-up and coaching.
Yeah, they have a lot of
then-
great resources, and the medical director's fantastic. She presented to the staff on DEI as well, all of the investigative staff, physical therapy, medical board, and our board.
We will continue our discussion from before lunch. It seems like we were getting close. Let me just recap what I understood, and then we can go from there. So it seems like we were in agreement in 2026 to switch to 6 in-person two-day meetings. Yeah, and I think Eileen, in a little bit of reflection, there was somebody threw out there like, oh, well, December could be one day. I think it'd be better to plan on full 2 days. And if we get to September or whichever month it was, August, and we're like, we really don't need that. But I think it'd be better to plan on more, to make them all at least 2 days, 2 days for the retreat one. But
Yeah, I'm open to what you all think is best. Also, excuse me, I did that because I was waiting for that, but I'll look at it later. The other thing that I was thinking about since last sitting here was I wondered if you all, and again, I'm open to doing whatever you want, but it was just something I was thinking was, would you prefer waiting to do those 2026, oh my God, dates, 2026? Thinking about 2026 dates, like in September or November, and kind of see this as a pilot project, or would you rather do it now? I'm open to kind of moving forward 2025 and then re-looking at what 2026 look like at a meeting in a few months.
I will just, well, obviously, I'm the naysayer. I would prefer it now. I mean, I like to make plans. I mean, visiting plans, vacation. So if we had the 2026 calendar, I would really appreciate it.
Well, and that will still be in June. I still will come to you in June. I need to sit and look at the calendar and say, right, and so I'll come to you in June with it.
Fair.
I just didn't know if you wanted it September or November, but either way, I can.
I think I agree with Board Member Callis, sooner the better.
Mhm.
And it seems like that starting on February was the best time to start that order. So then, sounds like if we're in agreement with that piece. Oh,
Were we still going to have for the chunks where there's larger periods of time, were we still going to have a couple virtual meetings this year just to?
Yeah, I wrote down for this year, we were going to be keeping August and December. But knowing that unless there's an urgent reason, there's really no reason to have it, but we have it there. So you guys can keep it bookmarked, placeholder. But again, I think one of the things I was thinking about too since leaving is, you were asking about how much time will be added on and how much cases will be added on. It's going to be dependent on what you all also direct me to come back in June with potential delegations. But I started to think about what each meeting entails, even just the short virtual meetings, whether it's the board packet, everything that's the public meeting, then getting in and the roll call. And then I was adding on a bunch of public stuff because I was trying to catch up on all the stuff that our amazing policy analysts were doing because I'm been aggressive about how we update our rules. I'll just say it politely, but yes. So I think like when you think about it, how much longer is it going to be? It might not even be, that 60, 90 minutes that I was thinking. I don't know. It'll be very interesting to see.
Just to bring it up, because I was thinking about it during lunch, even though the meetings themselves, like the 2 days, might be about the same, right? We don't know. We might get more efficient. I thought we were pretty efficient yesterday. I mean, like, we slammed through a lot of cases. Then thinking about board member compensation, because it will be the same amount of work, but spread over fewer meetings. So just, what do you guys think of that?
Yeah, I have thoughts, but I can wait and see what others think.
Can you remind us of what,
Yeah.
for our new board members?
Yeah, no, I think
What
that's
are,
great. I think
what kind of the
Yeah.
compensation is, the prep time, number of days?
Yeah.
And
Yeah, so I've let the new board members know, but I think it's a great idea to kind of give it some context. So I worked with the last two board presidents to ensure that we were making sure that everybody got reimbursed appropriately with a per diem. So right now, you all also just recently voted on increasing that rate. And what we do, it's the per diem rate for what a state legislator makes during per diem. And the way it is now is it's 2 prep days for every 1 day. So on your virtual meeting days, it's 3, and on your 2-day in-board meetings, it's 6. And I was thinking about how potentially, you know, the board packet could be out 3 weeks before, so you have that time. But then you also could get you know, you guys are going to have to direct me to come back. We have to look and open up Division 10 and have that discussion. But it could be a discussion around for every 2-day board meeting, instead of 4 days of prep, it's 5, right? So you add 1 on for each 2 days. That could be the conversation, but I would have to come back and ask, we would open the division and we could have that discussion. But the president before Aaron Green and before that, we ensured, you know, we value that it does take days work, and we want to make sure especially our CNAs and LPNs and everyone who takes a day off to do this gets compensated. I think that's what it could be. But I will come to you to have that discussion.
the math works out perfectly with what you just said. I mean, it translates.
Mm-hmm.
The 10, so you have 5 virtual days, you have 5 prep days, that's 10. We'd be adding a day. Be close, yeah. 6 extra prep days. I'm just doing the quick math.
Yeah,
It
it's
would
be
be
a little
equal.
less amount over the year because.
No, I'm saying over the year, I think it's.
Oh, because we're adding
roughly the
2,
same.
and then,
We're adding
I
2,
see.
and
Mm-hmm.
Well, adding those 2 and making the prep days 5 for 2 days in person.
Board President, members of the board, may I address the board? Okay. In regards to those 2 virtual meetings that we're discussing continuing to hold in 2025, the amount of preparatory work that goes in front of creating the packet, I think we would have to discuss thresholds for canceling or when we would decide that timeline, because it does take weeks in advance. So in my mind's eye, it makes sense to just plan on holding those 2 virtual meetings because of, again, the weeks in advance that we have to prep and create the packet and distribute the packet and such. I just wanted to bring that up. Like the feasibility of actually canceling those 2 meetings.
Best to just.
Seemingly, but I wanted the board to be able to discuss that.
What do you mean?
The creation, so investigators would need to know well in advance if they're going to submit.
Right. But the goal is to not have them unless there's an urgent need.
I think what.
They're saying just
Well,
placeholders
Matt,
for urgent needs, so they keep the day if we say an urgent need. Versus keeping them,
Wouldn't you also have the consent agenda items for that, for those months? Because part of the idea was you're not waiting 3 months for.
I don't know, I'm confused
For
now. I'm
action.
sorry, I got a little off track.
Well, I just wanted to address that matter because I hear us kind of contemplating 2 things. One, treating it as a placeholder for urgent matters, but also actually facilitating those meetings because we're worried about the amount of time that would lapse if we didn't facilitate those meetings.
Yeah, no, they weren't worried about that, catching back up. They were worried about if the date falls off the calendar and it falls off their save date, then they wouldn't have it off and forget. So it was a way to save it, so if we do call them, we could have it, but not plan on it. but I'm open to whatever discussion, but that was what it was.
It sounds like what Manager Ferris is saying is that the staff would need advance notice,
Yes,
whether it's going through or not, and how much advance notice.
I see.
Because if we flip it the other way of, if we're gonna hold a special meeting, how long notice are we gonna get to know about that?
What, different rules when it's a special meeting? I'm not sure. Yeah, when it's emergency, we'll have to look that up.
Cause either we do that or we go with the placeholder.
Yeah.
I have a question, for Manager Ferris. So for your staff and you, how much time, I guess and maybe I'm wrong here, but I envision that you and your staff are gonna be the ones who are gonna be like, this is we really need this meeting kind of thing. And so I'm wondering, how far in advance do you need? I mean, if it's an emergent situation, do you need to notify within a week, or do you have a lead up? I just don't know how it works.
Well, because I like to complicate the conversation, as you've witnessed just now. In terms of what we're obligated to do for public meetings law, that's one thing. But in terms of, it would be dependent on what we would constitute urgent public safety need. Is it those circumstances where we're talking about emergency suspension, or are we talking about finalizing certain things that would create immediate public safety outcomes, like stipulated orders, notices for certain actions? So I think some of that would be need to be discussed about what would constitute that type of meeting for us. But then we need to produce a packet and give you the adequate amount of time for review. And we're trying to account for that in this discussion anyway. So ultimately, it would take, we would need to know a few weeks in advance, it sounds like, in order to facilitate that meeting.
Well, hopefully not. Hopefully, if it's emergency, they allow it to be shorter, but if
For
it's not
emergency suspension, it is a
yeah.
different,
Yeah. Mm-hmm.
certain special meetings.
Yeah.
Please, could you clarify?
Yeah, just to clarify timelines, from the public meetings law perspective, right? So talking about how much notice has to be provided to the public prior to convening a meeting. So kind of you can have a special meeting, which is sort of an additional meeting that you would call, if you have a quorum. So there's a distinction there between special meeting and then what we would call like an emergency meeting. So an emergency meeting, you would need something with less than 24 hours notice. So the difference in the public meetings law is you have more than 24 hours notice and it's sort of other than scheduled, then it would be a special meeting. You have less than 24 hours notice, then it's an emergency meeting. So just to clarify, and then there are some requirements about, what would constitute things like that. But again, the goal being that the public is aware with enough time to determine if they want to come and so just so that you're aware of kind of the public meetings law timelines, that's what they are.
And then what about the inverse of canceling a scheduled meeting? What public notice do we need for that?
Good question.
Off the top of my head, I'm not sure if there's a legal requirement. That's something we could look into. Again, I think the overarching concept being, members of the public may be looking at this, maybe planning accordingly. So giving them as much time as possible to understand that something's not happening so that they aren't assuming it's going to be happening. But I can look into and come back on whether there's actually a set timeline for that.
Yeah, and I've only canceled once since I've been here, and it was an ice storm, and everybody's internet was shaky. I was ready to go with the generator and the cell phone, but I was like, that's not good, Rachel. No.
I'm looking at the mechanics of the August and December virtual meetings, and from hearing from Manager Ferris and kind of what preparation would need to be, and December 17th and where that falls, thinking after the previous meeting in November, 2 weeks seems like the amount of time, like 2 weeks ahead of time of the December 17th would be when, in my mind, you could cancel it. like plan on it, and then 2 weeks ahead of time, you're like, okay, we don't really need that meeting, or the reports or the staff. It doesn't need the board input at that point. That was what I was reading, is like canceling, or keeping those two, and then 2 weeks ahead of time, you decide whether or not. Does that make sense?
I mean, I definitely think that knowing a threshold helps, and we can make whatever decisions the board makes work, so.
Like, then I think the question is, what cases would we be like, we're gonna continue to have it? Because there will probably be always stuff cycling. So what kinds of things would be a high enough, do we want to determine that, or do we want to leave it up to investigations? I mean, I guess, 'cause that's also a question you had, right? Was, what kind of cases do we need to have in order to have the meeting?
I think you could leave it up to us, because we're the ones that are gonna know if it's urgent and needs to get in front of you, and we're the ones that would make that decision. But if they're gonna add anything to that.
Yeah, shy of producing a packet for the board to review and then determine if that packet,
No.
I mean, we get right back into that production
what yeah.
cycle, right? So I do think, much like we use discretion to determine when an interim agreement is necessary to have somebody step outside of practice while we're continuing to investigate, I think we could use kind of the same discretion to determine if something constitutes needing to come in front of the board sooner rather than later.
So would we be okay with planning on, I'm going to plan on being present for the August 20th and December 17th virtual meetings. And then we would count on board staff to make that determination at least 2 weeks ahead of time if it was going to be canceled. And that would give us adequate time to prep.
And then in our minds for next year, we would, without having any dates, we would know that the even months, we're probably going to have in-person meetings for 2 days. And are you thinking August or October for the board retreat?
So the next year. Well, why don't I come to you in June with some dates, and then we can figure that out. Yeah.
We all pretty good with
And we
those,
can also talk about it
with those
at
two,
September 1.
roughly those two changes. And then another aside, what's our June location?
Yeah, so why don't I make this motion and then we can
Okay, then we'll
do
get
that?
to that,
Okay. Any final words?
No.
I have one.
I'm like,
Let us know.
yeah, she does. Okay. So then I make a motion that based on the information provided, board staff cancel board meetings scheduled on May 21st, July 23rd, October 15th, March 18th, 2026.
year?
Yeah, do you want to say the
I
years?
think you need to say the years.
Yeah. Okay. Thank you for that.
Beginning.
Okay, I'm starting again. I am making a motion that based on the information provided, board staff cancel board meetings scheduled. Now let's see if I can read them because I've crossed them out. May 21st, 2025, July 23rd, 2025, October 15th, 2025, March 18th, 2026, May 20th, 2026, July 22nd, 2026, August 19th, 2026, August 14th, 2026, and December 16th, 2026.
October 14th.
October 14th, 2026, and December 16th, 2026.
So moved.
Seconded.
It's been moved and seconded. Let's do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Kalis.
Aye.
Linda Stanich.
Aye.
Oleniki Tolbola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Great. So I will come to you in June with some information about the delegated authority and 2026 dates and per diem. Okay. All right. So I'm so sorry that I forgot to put it on the agenda on following up or any emails. There's been a lot going on. So based on the board wanting to be in the community, in our rural communities, so in June, and we mentioned Southern Oregon and the coast, and then September, the coast. It's finally been kind of confirmed this morning, so I will send an email out with details, and Brandy will start working on ensuring we have a place to stay. But we will be in a long-term care community-based setting, Rogue Valley Manor in Southern Oregon. So that's in Medford, right on the line of Ashford. They are very happy to host the board. And then in September, we will be at, let me say it right, Adventist Tillamook over on the coast in September. So I'm excited to bring the board to Southern Oregon and the coast, and then next year we will go to Eastern Oregon when we know what our dates are. Once we'll travel. So any other questions about that? Brandy will start sending information so we make sure we find a good place to stay.
And I'll leave us with one final thought too. When we're thinking about efficiencies, particularly for our discipline discussions, please, if any ideas come to mind, I'm going to volunteer Rachel to receive those ideas.
Yes,
So
email me,
send them,
not all of you
yeah.
together and each other, me.
For like formatting wise,
Just a little reminder.
there's things you think or you like, or a new idea that we could try to try to be more efficient and to try to continue to put out good work. Yeah, well, I think we're game to try it out next time.
I love hearing all the ideas. Okay. And remember, I'll say that too. That's how I then know what to come to you with, or the policy analyst. So remember that. Thank you. Thank you very much for another great meeting.
Yes. The meeting is adjourned at 2:29 p.m.